So I'm just trying a whole bunch of different things and seeing where life takes me. That's all.
Hi, my name is Sabrina Atienza. I'm a rising senior at UC Berkeley. I'm a double major in physics and computer science. For the past 6 months, I've been working at IBM doing stuff for databases, HBase, Postgres. Right now, I'm a lead software engineer at Health 2.0. I'm also in the alpha class of Agora Startup House, which is UC Berkeley's first residential incubator. My partner George, who's the one coming back from boxing, we're pursuing a healthcare tech startup, which may or may not be a personal analytics engine or even a genetic search engine. I play guitar and I've been playing metal for 8 to 9 years. My favorite band to play is Metallica.
You're muted. Wait, why are other people muting him?
Yeah, it says that.
Wait, I think I just. Okay, we're all muting him. That shouldn't be happening. Yeah, I unmuted him. This, this is like one of those if a tree falls in a forest and nobody's there to hear it and actually make a sound. Is this lecture actually happening or?
Wait, all right, is that any better?
Yeah, we got you now.
Am I back now?
Yeah, you're back.
All right, I'm back. Okay, so I was talking to myself.
Yeah.
All right, good. All right, can you hear me now? That's me. Good. Okay. All right, sorry. Okay, so yeah, I'm Stel Smith, and I've been in the industry. I've been in health IT for about 20 years. I actually went to medical school, Medical College of Virginia, and I have a master's in health administration. And basically, my physician, my dad's a doctor. He's an OBGYN doc. My mom's a nurse. My grandmother was a nurse. I was raised basically in an emergency room. And what I've done is I've been involved in every aspect of health IT, from medical billing all the way up to clinical demonstrations. Now, I've worked at a company called WebMD back when WebMD did more than just a magazine. Basically, in WebMD Practice Services, what we did is we helped physicians implement technology in their practice. Now, I mean, 20 minutes, there's so much to go over. I mean, I got some email questions, and I'll go over those kinds of things. But, you know, really, my background, as I said, evolved from medical billing all the way up to basically doing every aspect of launching a product, from research and development all the way up to product launch. Oh, by the way, I'm supposed to tell you about one of my interests as well. I actually Derby ref. I don't know. You see my picture here. I've actually, when I lived in LA, I was actually a roller derby ref for the Los Angeles Derby Dolls, and also for the Jersey Shore Roller Girls. And I'm actually a certified rep for both OSDA, which is Old School Derby Association, as well as WIFTA, which is Women's Flat Track Derby Association. And I travel everywhere I travel, all across the world. Everywhere I go, if I bring my skates, I actually can find a roller derby place to actually go and practice with the girls and everything else. So I was just kind of that was supposed to tell you about that, but that's not really relevant to health IT. So, all right. So, you know, there's a lot of things that are important. Let me start from the very beginning and say the purpose, and I'm going to speak very frankly, I'm an East Coast guy, so, you know, I apologize in advance. I'm a little rough around the kind of an acquired taste, so I'm going to be a little bit more frank than most people you may deal with. But I'll tell you the purpose of all this crap, right? When we talk about health IT or DICOM images or PACS images or electronic medical records or business intelligence for data mining, SNOMED, medicine, whatever it is, the purpose of all this crap from a business perspective, if you're looking at the American healthcare system as a business, the purpose is to combine procedure codes and diagnosis codes to maximize reimbursement. Now, you can make the argument, and there's other reasons you get into medicine. You get into medicine to help people. If you're a physician, you want to get in, you want to help people, and you want to make a difference in patients' lives and everything else. But if you want to survive, if you, as a business, the purpose of every shred of healthcare IT that's out there, I cannot stress this enough. The purpose of everything out there is to combine procedure codes and diagnosis codes to maximize reimbursement. And remember that. If you remember nothing else from what I tell you, remember that fact. Because when, and I'm going to talk about those a little bit more, but as you're looking at a product or as you're looking at a technology or as you're looking at something new and exciting, what I do for the past 20 years is I look at that thing and I say, okay, how is this thing going to help me as a doctor, as a clinician, combine a procedure code with a diagnosis code to get more money into my practice? And if I can't answer that fundamental question, if I cannot see that in a straight line, I'm wasting my time. So that should guide every decision that you make, everything that you do in a startup perspective, whether it's patient-centered, you know, if you're looking at it from the patient's perspective, looking from the physician's perspective, or the hospital's perspective, the reality is what you should be thinking first and foremost. Again, you know, I'm ignoring the fact, obviously, that we're talking about patients' lives, and you want to make patients better and healthier and everything else. I mean, I'm not talking about a philosophical type of argument. What I'm talking about is from in the United States, the main, if you want to be a physician or you want to be involved in health IT, you need to be able to get money in the practice. And the way that we do that today is by combining procedure codes and diagnosis codes in a way that gets money flowing into a practice. Now, some of the things I sent you, the current way we do it today is physicians use something called a CPT code, the current procedural terminology. And a CPT code, you know, there's thousands of them. And there are different ranges of codes and everything else. But basically, they're 5-digit codes typically. And these 5-digit codes tell basically what service the physician performs. So, for example, if I'm a and it's so funny because there's so many things I need to back up and tell you, but the procedure codes, whatever the procedure code is, that procedure code currently has a price associated with it. So let's say I'm doing something called an evaluation management. When I'm a physician and I'm seeing a patient, one of the hallmarks, one of the major bread and butter things that I do is I evaluate the patient and I manage the condition that they have. That's called an E&M code, right? It's the bread and butter of whatever physician. When a physician looks at somebody the first time, they're doing an evaluation of the problem and management of that problem. There's 5 of those codes, and you don't have to write it down. I mean, just to give you an idea of the complexity. So there's a level 1 through level 5, and level 1 is real simple. I came in, I have a hangnail, I need to get it pulled off, no big deal, I'm in and out, I have no other problems. That's a level 1 evaluation. It's a simple, it's problem-oriented, I know what the problem is, I don't have anything else to worry about, I can do it and move on. A level 2 evaluation management, or an E&M code, is a little bit more complicated. And it goes all the way up to a level 5, which basically says in 24 hours, if I don't intervene with this patient and do something, they're going to die, right? So that's somebody who has multiple organ system failure and lots of problems, and it's really complicated. You got to spend an hour and a half with the patient, right? And you get reimbursed based on the level of complexity. From that level 1 all the way up to level 5, you get reimbursed on a sliding scale based on the level of complexity of what you do. And then when I evaluate and manage them from a procedure perspective, I'm evaluating and managing a problem. Well, that problem is the other set of code, which is ICD codes. That's the International Classification of Diseases. We're really talking about ICD-9, CM, who cares? international ICD codes are basically what's wrong with you. So if you think of the procedure code as what the doctor's doing, the diagnosis code or ICD code is what's wrong with the patient, right? And these codes are anywhere from 3 digits to 5 digits, and they can be specific or not specific. It gets really complicated from there. But basically what I do is, if I'm a physician, no matter what kind of physician I am, I take a CPT code, like an E&M code, a 992, whatever, and then I attach that to a diagnosis code. And that's why I see you. So if I have a chest cold, I go in to the doctor and I say I have a chest cold, or I have a headache, or I have a shoulder injury, or whatever it is. That injury or that headache or whatever it is, depending on what it is it a hypertensive headache? Is it not a hypertensive headache? Is it this? Is there diabetic neuropathy involved? Whatever. On and on and on. It gets more and more complicated. But basically, I see a doctor for a reason. That reason, from the doctor's perspective, is a diagnosis code. And what they do with me are the procedure codes, so CPT and ICD-9 codes. Now it's the simplest concept in the world, and you may already know this. I can tell you that although you've understood that simple concept, you could spend the rest of your lives studying coding, medical coding, which is combining procedure codes and diagnosis codes, and never get it straight, because it is really complicated to do it well and to do it in a way that makes sense and everything else. So again, without numbing you with too much detail, but there's different procedure codes that you can put together. So for example, if I'm a urologist, right, and I see a patient and I need to do a surgery, and let's say I'm seeing a gentleman who has a prostate that needs to come out, okay? So when I do the surgery, I have an E&M code or I have a code that actually deals with the surgical procedure of removing the prostate. I also have a procedure code for inserting the catheter into the patient's bladder so that I don't get urine spilled all over the place. And there's a surgical tray and a bunch of other things as well. So all of these things are all connected. So I may have 4 or 5 different procedures or CPT codes combined with one particular diagnosis code or one particular reason, okay? So as a doctor, I have a right to bill all of those things. I can bill the surgery code, I can bill the tray fee because the tray costs money to do that, I can bill for the catheter being put in, I can bill for the catheter materials, I can bill for the blood test, I can bill for all that stuff. Now, even though I have a right to do that and I have all these codes that actually have dollar signs attached to them when you think about it from a business perspective, there's nuance to it. So in other words, if I do a surgery where I'm removing a prostate and I have to insert a catheter, if I have to do it as part of the surgery, what insurance companies say, which is the next important thing I'm going to talk about, what insurance companies say is, well, if you have to insert the catheter every time you do the surgery anyway, we're going to bundle that in. So don't bill that separately. Include that in the procedure that you're doing. So they'll take money away from you. So I may have 10 procedures that I do. The insurance company will look at that and say, well, in reality, because you have to do it every time, we're going to take away 5 of those procedures, so you really can only bill for 5 of them. So again, this is really complicated stuff, but I'm trying to make it as simple as I can. Again, the whole purpose, combine procedure codes, diagnosis codes to maximize reimbursement. So the insurance companies, the next level of this, the other big, if I were to tell you something about the industry that makes the most sense, is in addition to remembering that procedure codes and diagnosis codes to maximize reimbursement, you need to see that in a straight line from anything that you're doing. I'm going to sound like Rain Man with that, but the reality is that you really have to understand that, and you have to see how is this going to help you make money. Well, then the other piece of that, the other side of that is how is it going to make you money? And if you take out of this call, the business of healthcare in the United States is procedure codes and diagnosis codes to maximize reimbursement. If you take 2 things out of this call, the second thing you should take out of this is that somebody has to pay for this. And the most important thing, in addition, from the doctor's or from everybody's perspective, is where is the money? Where is the money coming from? Is it coming from the patient? Is it coming from the insurance carrier? Is it coming from another entity? Where is that money coming from? Because the people who are giving the money or holding the money, the purse strings, they determine what works and what doesn't work. Okay? So, for example, I can be the best surgeon in the world, and I can do the best surgeries in the world, but if I bill all level 5 E&Ms, and I'm the most expensive surgeon, basically who bills every code that I possibly can, and I have 50 codes on there, an insurance company will only pay what they're willing to pay. Now, there are rules that they go by, which basically there's like the McMillan rule and a couple others, where they have actuaries and whole schedules of how they pay and what they don't pay. And you can fight all of those rules, but really insurance companies drive, because they're the ones who predominantly are providing the money to the healthcare providers. They drive what gets paid for and what doesn't. Okay. So again, procedure codes and diagnosis codes to maximize reimbursement is the number one thing. The number two thing is, where does the money come from? Because where that money comes from and how that money is disseminated actually determines whether or not something is going to be success, whether a program or a policy or a product is going to be successful. Have I numbed everybody to sleep yet? Just wave if you. I know you're on mute, but are we okay? Thumbs up, thumbs down. All right, cool. Okay, so again, procedure codes, diagnosis codes, maximize reimbursement. So if I look at that, if I'm looking at a DICOM image, right? A DICOM image. If I talk about a DICOM image, old school. If I wanted to do an X-ray or an MRI, I would have to take the picture, do whatever I want to do. I have to develop it on film and hang that film on a light box and look at it. Okay. What DICOM is it's actually an industry standard. It is the industry standard. Instead of looking at a film, of looking at that image on a computer screen. Okay, so the DICOM rules basically says you have to have such and such resolution. You have to have this type of monitor. You have to be able to view this image and scale and rotate it and do everything. There's a lot more things you can do with a computer image than you can with with a piece of film. So DICOM is kind of the standard that the radiology industry uses to display images. Okay, so along with those images, when you capture digital media, there's a lot of data that comes along behind it. Well, if I look at that and I say, okay, how is this DICOM product or this viewer, this thing that I'm looking at, where I'm looking at an X-ray or an MRI, how is that making me money? Well, the way that it's making me money, when I look at that, I say, okay, how many images can I view on my computer screen versus hanging them up on a light box, and how better is my diagnosis ability because I can zoom into different areas. So if I get a 5% better read rate on my images because I have a computer screen where I can zoom and flip and change the contrast and do things that I can't do on a piece of film, and I get 5 or 10% better, that actually equates to money in my pocket, or the ability, or if I can do it faster, I can see more patients and everything else. So, that's an example of when I look at a technology, how can I take that, or how can I make money, or how am I combining procedure codes and diagnosis codes to maximize reimbursement? When I take that picture of that X-ray, let's say it's a chest X-ray, there's a CPT code that correlates to that chest X-ray. For taking the chest X-ray, there's a CPT code. There is a CPT code that actually includes the professional component for the radiologist to read that X-ray. There is the technical component for the radiology center to provide the chemicals and the media and the equipment to take the picture. So each CPT code has a professional component, technical component, everything else. So you can see it gets more and more complicated, but really it's from a concept perspective. Procedure codes, diagnosis codes, maximize reimbursement. Where is the money coming from? How is the money being sent out? So now that I've kind of talked about that, I'm going to back up for a second. And we're going to have a ton of questions after this. That's totally fine. But let's talk about how somebody like me, when I'm in the healthcare industry, how we break down the healthcare industry. There are 3 types of physicians. When I'm talking in the physicians, I'm talking about the outpatient market, not in a hospital. I'm talking about the physician in the field who may go to the hospital but actually has their own office, okay, and they see patients out of the hospital in the office and do procedures. Okay, there's only 3 types. There's a primary care physician, and in addition to the primary care physician, there is a surgical subspecialist, and there is a non-surgical subspecialist. Every type of doctor can be categorized as one of those 3. If I think of a gastroenterologist, they're really a surgical subspecialist. When I say surgical, I'm not meaning surgical in the classical sense of the word. I mean they perform procedures that are invasive. It could be an endoscope. It could be, any type of procedure where I'm jamming a scope down your throat or up your butt or any place. That's a surgical procedure, and I'm a surgeon. So what I care about as a physician, I care about certain things. I care about how quickly I can get to the hospital, and I have to dictate notes that go to the primary care doctors and everything else. The non-surgical subspecialist, that's somebody like a nephrologist, as an example. So a nephrologist or an endocrinologist, they don't do procedures pretty much, right? What they do, they hate it to refer to them this way, so please don't do it outside of this call, but it's cookbook medicine. And cookbook medicine is try a little bit of this, a little bit of that, we'll take some blood, we'll see how you do. A little bit of this, a little bit of that, let's see how you do. So an endocrinologist, how's your blood sugar? I don't know. Let's try this. Let's try that. Cumulin. Let's try fast-acting, insulin. Let's try slow-acting. Let's try this. Let's try that. Let's try diet. And they care about other things than a surgeon would care about. And a primary care physician, what they care about is the ability to gatekeep all of this information. So the surgical subspecialist and the non-surgical subspecialist, they live and die by the referral of the primary care physician. So the primary care physicians, they need to cater to them. So if I go to my doctor and I see them and they say, you have a problem that's too complicated, I need to send you to a specialist, they send me to a specialist, that specialist has to send a letter back to my primary care doctor telling them what they did, why they did it, what they're going to do, and how they resolve the problem. So that information now flows back on paper, right? So the primary care doctor needs to get, so now I'm going to see the same doctor for 20 years. Well, if I have a gastro problem, a lung problem, a heart problem, an endocrine problem, I'm seeing all these specialists, the primary care doctor. I need to manage all of this crap in one place and make sure that I'm counseling the patient and taking care of them and bringing them through this maze of complexity. If I'm a surgeon, I don't care, I'm going to see you, I'm going to cut you, I'm going to fix you, I'm going to see you afterwards, I never want to see you again, okay? That's not the same relationship as a primary care doctor. If I'm an endocrinologist, I'm going to see you forever. You're going to have 50 medications every time you see me. You're going to be very, very sick. You're going to usually be old. So I need to have the temperament to be able to handle that. So why is that important? And by the way, any type of physician, you can throw out any kind of physician, you can categorize them as one of those three types: primary care, surgical, non-surgical. And when that becomes relevant is the products and services that are relevant to them, to those types of physicians, will be different based on their workflow, how they work through the day. If I'm a pediatrician, I never go to the hospital. I go to the office, I see my patients. If they get sick, I send them to the hospital. Some hospitalist sees them. I go to the office, I have to manage paperwork, I have to do prescription. My day looks very different than a cardiothoracic surgeon who sees a patient in the office once or twice a week, then goes to the hospital, does his rounds for the patients that he operated on yesterday, does surgery on maybe Thursdays or Fridays, cuts people open, does whatever he's got to do, sews them back up, sends them on their way, sends them back to the primary care doctor, sends a nice letter, thank you for the kind referral, send me somebody else, and that's their day. Versus the nephrologist who, patient's very sick, they have diabetes, they have hypertension, hyperlipidemia, the standard trifecta, they send them there, they have to manage all their meds, all their problems, all their issues, they have to take blood all the time, and it's a really complicated dance, so they need to communicate a little bit more with the patient and also a little bit more with the primary care doctor as well, but they need to be up and advanced on what medication interactions there may be, right? Primary care doctor needs to be as well, but it's a much greater extent when you're dealing with a specialist. So products and services, if I have a dictation system, right, so I have a great new handheld, on the iPhone, I can dictate into my iPhone and it types out a note and everything's wonderful and it allows me to do hospital rounding. And I go into a primary care doctor's office and I go on and on and on about my hospital rounding software and how wonderful it is. I've wasted 45 minutes of my time, right, because they don't care. If I go in and I talk to an orthopedic surgeon about a lab interface and the ability to do lab work and blood work and send medications electronically and everything else, and I spend 20 minutes on that, they stop listening to you because they're a surgical subspecialist. They don't give a crap about any of that stuff. What they care about is how can I dictate, how can I see my patients in the hospital, get them in and out, send letters back to the primary care doctor, and move on with my day. So they give a crap about lab interfaces. They don't give a, I mean, an orthopedic surgeon, they know 4 drugs. That's basically what they do. You know, you can open an emergency room with 14. Orthopedic surgeon, they do 4 different types of drugs. So again, when we look at products and services, again, from the provider side, extracting information and the types of services that they're going to be interested in is really reflective of the type of medicine they practice. Thumbs up? Are we cool? Okay. So, the other big thing that I wanted to talk to you about is data extraction and pulling things out, and regardless of the type of physician, you know, when we talked about combining procedure codes and diagnosis codes to maximize reimbursement and getting money into the doctor's hands, and where does that money come from? Well, think about it. If I'm in a paper world, think about if you go to think about your family doctor now. Okay, you guys are kids, you may still be seeing a pediatrician, you may be seeing an internist, who knows. Think about the last time you went to the doctor's office, and think about if they have paperwork right now. And if you walked into them and said, Dr. whoever, how many diabetic patients do you have? Do you think they could tell you? Could they? If you asked them, you know, if you asked your doctor in a paper world, how many diabetic patients do you have? Do they have any idea? No. Then if you say, of your diabetic patients, what's your average hemoglobin A1C level? You think they know? They don't have a clue. They have no idea. Okay. How many patients who have coronary artery disease do you have on an ACE inhibitor? Because that's the latest thing of what you need to do. I don't know. By the way, doctor, there's a new letter that came out today. This medication actually causes heart defects. Vitorin actually causes heart defects. Can you do me a favor and get me a list of all the patients who are on Vitorin who are currently taking it, because I actually need to contact them to take them off the medication? Do they know how to do that? No. In a paper world, you can't do that. That's where health IT comes in. And health IT and the business that we're in, how do we get that information? Okay, well, you use a computer. Now, getting the providers to use computers and point of care and everything else, you know, I was also going to talk to you. I sent out some information on Dr. Snow. I told you we're starting in 1854. What I'm talking about is the evolution of where we are in healthcare. In health IT today, data is king. Data is where it's at, and extracting of data, manipulating data, doing things with data is where we're going to be for the next 50 years. If you think about this, this is something that's very shocking to doctors. Do you guys all have ATM cards? Do you know what an ATM card is? I'm old enough where I actually have something called a MAC card. It was called a MAC card, Money Access Card. And 20 years ago, if I took that MAC card and I drove down to Richmond, Virginia, and I tried to use that MAC card in the ATM, the MAC machine down in Richmond, it wouldn't work because it couldn't connect to my banking information up here in New Jersey, on the Jersey Shore. So imagine if you used your MAC card today or your ATM card today and you couldn't communicate and you couldn't use it as a debit card and everything else. Well, if you think about it, healthcare is in that same boat. If you travel, if I'm on the Jersey Shore, I travel for a living. I travel all over the world. If I go somewhere and I talk to a doctor in California or, you know, Hawaii or any place else, they have no way to know what my medical history is. They have no way to know what medications I'm on, what surgical procedures I've had. So if I can't tell them and I can't relate it, how do they get that information, right? So we're at the beginning point of this health IT revolution of getting information into the doctor's hands. Well, the big question now is how do we get that information in, you know, from the doctors to share that information? And that's through the insurance companies. And the insurance companies are the ones who are paying the bills, and they're requiring information. Well, people always say, how come doctors don't use computers? Well, why should they? If I go in, if I ask Francis, he's a physician, if I go in and I say to Francis, you know what, I have a headache or I have a cough, when are you going to cure me? What's he going to say? He's not going to say anything because he has to ask me a whole bunch of questions, has to get a whole bunch of data out of the system. Well, what's in his head when he sees me, when he sees how I interact, and he sees how I answer the question, not only the way I answer it, but how I answer the question, taking that information and putting it onto a computer screen. and making that data mineable and extractable. That is where we are, and that's where the big bottleneck is, because physicians don't want to do that. They don't want to take the time to actually go through and extract that information and take what's in their head and put it down on a piece of paper, and sometimes they can't. So I'm going to wrap this up soon because I know we have to get to questions, but you know, what happens is this data extraction, or the ability to do that in a hospital environment, which is the other type of physician. If you talk about an inpatient or a hospital environment, they have teams of nurses and teams of people who enter data into a computer system that is all extractable and reportable. Now, where do you report that information? Remember what I said about the money and the insurance companies? This is the first time in history that Medicare, CMS is called as Medicare, Centers for Medicare and Medicaid is CMS, cms.gov, if you go to the website. The first time in history, Medicare has done a nationwide program where they are reimbursing physicians $44,000 per provider over a 5-year period for the adoption of electronic medical records to put point-of-care information into the CMS's hands so that they can pay doctors based on how well they're keeping their hemoglobin A1C levels down, how well they're keeping their diabetic patients happy and healthy and everything else. And the way that they're doing that, which is the last piece of this, is with a whole bunch of tools that are out there on the patient side for the patients to start to get involved in healthcare, and then also on the provider side where the providers can enter information, and then on the back end side where I can extract information using nomenclature like SNOMED or medicine, which is what CDC uses SNOMED, Department of Defense uses medicine, to extract information out and do disease trending and analysis of information. So I don't want to get too complicated and too far off course, but basically we have an opportunity, or where we're at right now is we're almost at a tipping point where physicians are starting to embrace and adopt this technology, but there's still a huge gap between taking what's going on qualitatively in a physician's head and putting it down on a computer and making that information extractable, and then most importantly, reimbursable, if that makes sense, and who's going to pay for it. So I could drone on and on and on for hours, but I mean, that's basically where we're at and the highest level of information that I can give you. So I have a bunch of samples, a bunch of other things that I can talk about, and programs that are out there. Really great work, but I can open it up and for questions if you want at this point. No? Yes? No one. I've numbed everybody to sleep. Everybody's asleep.
I have one. Hold on. Let's put my mic for the so. So, can you guys hear me, by the way?
Yeah, totally. I can hear you.
Okay, so my question was regarding the process of developing a value proposition for doctors to log this information into the computer, because they already have software to dictate, and it seems to me like the only real way to solve the problem is to go through use case by case by case until you have something to where a doctor can, almost in the same way as they type, just select options and ranges and quantify to the best of their abilities, because that's what they do right now. And if there was some type of easy touch interface to do that, I don't see any other way to do that than to go through each use case. Does anyone else? Or
well, I'll tell you, I mean, it's interesting, but that's what we run into, and that's what we do in the industry. I mean, that's, but one of the things I will disagree with is that when the doctors are getting fed a lot of this information, right? So in other words, when they do a blood test, they're getting the ranges and they're getting everything, and they're making judgments that are based on information that's being fed to them. But there's also a whole bunch of stuff that's not included in when I'm doing point of care documentation, right? It's not only am I answering the questions, but how do I look? What's my affect? And there are a whole bunch of other things where,
how do you look?
In other words, do I look like I'm telling the truth? Am I making eye contact? Am I sweating a lot? Am I, avoiding certain answers? Am I uncomfortable? Am I reacting appropriately? There are a whole bunch of things that are that are going on up here. When you walk in, believe it or not, when you walk into a doctor's office, you don't have to open your mouth. They know exactly what's wrong with you before you even open up your mouth. They'll ask you a couple questions and everything else. The thing is, what we do in the healthcare industry is we try to say, where is that happy medium? Where can I take data points that are relevant to the exam and make the doctor select those? And how do I do that in a way that's least obtrusive to the physician? Now, the physicians would say those who dictate, because remember, primary care doctors don't dictate, right? So what do you do with them? But ignoring that, the ones who do dictate, if I dictate a Word document, okay, and I want to find every instance of the word diabetes in a stack of documents, it's very easy to do. Now, if I want to find every instance where the word diabetes is there, but not the word lactose, between the ages of 18 and 64, who had this, but not this, with this insurance, who were referred by this doctor, who may have tried this other medicine, who had a father who died of this and a mother who's still alive of this, but went through a 5-vessel cabbage. All these things, it snowballs and gets so complicated. Where does it stop? You know, so the feedback we get from the physicians is, I can either spend my time treating patients or entering data. I agree. I think it would be great if it was a great UI to do that, or a great way to enter information into the system. It's what we run into all the time. So I'll tell you what we've done today. Okay, what we've done today is we basically say, what information do you have to have? What can you live without? What do you have? What can you not live without? And can we capture that information and make it mineable? But it's a really tough sell, because if I had to enter, Francis tells a wonderful story. When I first met him, he told me a wonderful story about when he was a physician, and he was so proud of his first history of present illness that he did. He went in. Francis, why don't you tell him that story about how you got in trouble?
Oh, I was just going to say, have you had experience with other medical systems, like outside of the U.S., and how would you say that it compares?
I have. Okay, that's fine. I have. I've had experience with the English, the NHS, National Health System of England and Great Britain. I've had experience with the German health system, and actually I presented to Republic of Korea the medical manager software, and also in Dubai. And I have to say, the big difference in all of those systems is that they start from a different premise from us. They start with a common database, right? So in German healthcare system, perfect example, there's one database or one laboratory that handles all the labs. That ain't the case here. You got Quest, you got LabCorp, you got Orchard, you got the hospital lab, you got everybody else. None of them use everything. Maybe they use Loink, maybe they don't. But in the German, every other healthcare system that's out there in the world, the international market, typically starts in a very different place from where we do. And if you have control and you can create 1 or 2 or 3 databases with which you can build data and capture information and do things, you have the ability to affect change and make difference in that kind of environment. Versus the U.S. healthcare, it's totally fragmented, totally on paper, with different databases. Some of them even don't have databases, or proprietary databases. So I'd have to say that that's probably the biggest difference. And the thing that you'll find in the international healthcare market is mineability of data and bioinformatics, doing genotype versus phenotype stuff. I mean, that's in Qatar and Dubai, and in addition to the medical tourism stuff, which is really exciting stuff, telemedicine is a really big deal. I mean, there's this imaging solution that actually it's a high definition ultrasound that resolves down to the cellular level that they're using in Germany. And imagine being able to image a lesion on the skin that's this big with a high definition ultrasound that resolves down to the cellular level and actually allows you to remove in one sweep the tumor, versus in the United States where you have to do Mohs surgery, where you cut a little bit out, you wait 4 hours, get the pathology back, cut a little bit out, wait 4 hours, see if the margins are clear. But because I have a single database solution in Germany and I have the ability to connect it, and I can add technology like this high-definition ultrasound from GE, I can actually extract and I can take it out in one swoop, and I can get data and share that information among providers very, very easily. Versus here, you just can't do that.
Thank you so much. That
No
was
problem.
very helpful. And thank you so much for your presentation today. It was
Anytime.
super, super helpful.
Anytime. All right, so where was I? What was the question? I'm sorry, I forgot your. Where was I? What was I answering? That's great. Yeah, it's a great story. Now, and that's the fundamental thing that you run into is what's the balance between quality of care and quantity of care, and that actually, that story, really stuck with me. It really stuck because it essentially epitomizes what we run into and what happens. Like how much information do you capture and what can you get away with? And unfortunately, it's driven by how much money is paid and how we're reimbursed in the American healthcare system, and you're reimbursed for procedures. The primary care physician who manages diabetes, for a patient who doesn't comply with their diet, what happens is they get $30 every time they see him every 6 months and everything else. Well, if they don't listen and they choose to get a leg cut off by the surgeon gets $3,000 for cutting off the leg. So that's fundamentally, I didn't comply. I didn't do what I had to do. So now I can go, but the procedure is worth more money, so the surgeon takes it off. But the doctor who actually treats me on a daily basis and can counsel me and talk to me gets paid maybe $60,000 a year. That was a big wake-up call for me. Is my father is a physician in Richmond, Virginia. He's an OBGYN at the largest group in Richmond. And he sat me down when I was in medical school, and he said, listen, I make 30 cents on the dollar. You will make $35,000 a year and live in a crack house for the next 15 years of your life while you pay off $500,000 in medical school loans. And during that, you will actually affect your medical career. You'll affect somewhere between 5,000 and 8,000 patients' lives. That's about the lifetime of your career. That's how many patients you'll help. And is that what you really want to do and make 35 cents on the dollar? So I slid over and got my Master's of Health Administration, and sitting on CCHIT, I wrote criteria for personal health records and e-prescribing that have probably saved millions of lives and affected millions of lives. But it's a lifestyle. If you want to do it, I certainly wouldn't recommend. Primary care is a very noble profession to go in, but you should definitely be aware that as it stands today, it's really hard to sell somebody on having $750,000 in school debt, and you're only going to make $80,000 a year if you're lucky. Sorry, go ahead. Next question. I can numb you to sleep for hours.
Oh, okay, go ahead.
Okay, thanks, Ivan.
Yeah, no problem.
I'm wondering, who are the types of people or companies even attempting to build these tools for data aggregation and mining?
Well, I'll tell you, the data aggregation, it depends on what facet of healthcare, of how you want to get into the healthcare market. So you look at companies at Health 2.0, like Kias, as an example, Kia. their patient center, their wellness center, right? So they're entering it from the patient side. So they're getting money and revenue theoretically from the patients, and they're entering it about a healthy lifestyle and live strong and everything else. There's a couple of great companies out there, and I have these by email, but I want to, because this is in a way to answer your question. There's companies like, what's the name of it? Voxiva, and Voxiva, VOXIVA, and they did something called, Paul Meyer's company, yeah. They did something called Text for Baby. If you go to Text for Baby, TEXT, the number 4 baby.com, and you put in your due date, and you do it in English or Spanish. You go and you actually go to that website and you put in your cell phone and you put in your due date. They worked with the CDC, and they actually send clinical alerts and reminders for pregnancy throughout the history of the pregnancy. And so that's a company that actually worked with the CDC. They get money from wellness company, or from actually ISIS. I know Deb. She's a fantastic friend of mine.
Deb.
Yeah.
She's so funny.
Yeah, I mean, I own the relationship with Planned Parenthood. So in Planned Parenthood in the state of California, we did something with ISIS, and we did some stuff with LAUSD, where you did some sexual education and stuff like that about STDs. And in that case, the money or the type of the company was paid by Planned Parenthood or by ACOG or by the CDC. And actually internationally, another place that the money came from is Voxiva. How I got involved with Voxiva, I got a minor in Swahili, believe it or not. I know, I've never used it. I got to use it once. And what happened was Voxiva actually created a series of HIV alerts and everything, a whole program about HIV wellness in Swahili. I had to translate it into Swahili, so I helped through some of that. And Swahili, and it had cultural ramifications and everything else, so you had to send messages like Jambo, and they would respond back, "See Jumbo," and then you could, go and ask them about their levels and everything. It was a pretty cool thing. But the money came from the Ministry of Health, right? So that's been, on the patient side, where the money comes from. The types of companies that involve are Kias, Voxiva is another one, Medicomp. If you want to look on the other side, if you want to look on my side, which is my side. I mean, I've done most of them, but the health IT side, from the physician side, you look at NextGen and GE and Medical Manager or Greenway as an example. And all of these companies on the ambulatory side, they invest in products that allow the physicians to capitalize. In this particular case, CMS has a program called Meaningful Use, and Meaningful Use is that $44,000 per doctor. Well, to capitalize on Meaningful Use, you need to have a certified electronic medical record that meets the criteria for Meaningful Use. Well, most of them out there do that, and they have to provide these reports. So the money comes from CMS, reimburses the doctors pay the companies like GE or NextGen or eClinical or whomever. They also pay hospitals to be what they call an ACO, like an accountable care organization. So I know there were some questions about data models and reimbursement models and stuff like that. The money comes typically from, if you're talking about insurance carriers like CMS or Kaiser Permanente, fantastic. Julie Murchison used to work at, I don't know if she still works at Kaiser, but when she worked at Kaiser, I mean, there were some great programs that were out there that actually reduced heart disease and reduced diabetes incidence and did tremendous things. They were founded on the old staff model HMO, which basically you didn't have a lot of control. It was one database. You had to do everything through Kaiser. They're starting to open up now, but their model proved that if I control everything, I can reduce heart disease. I can reduce all these killers of men and women and children. So the money came from that particular aspect of it. So again, so the patient side is one piece. The insurance side is the other piece, where the insurers they're kind of paying, but really the physicians are the ones who are actually paying. And then there's other companies that just do hospital or inpatient things. There's whole companies that do something called revenue cycle management and managing money getting through practices and through hospitals as part of a patient-centered medical home, as an example. Patient-centered medical home is another concept where if you provide metrics and provide data using an electronic medical record, you can't do it on paper, if you provide information to the insurance company, they give you more money. So it's typically insurance carriers or patients. Now, these two entities, right? So I have patients over here and I have insurance companies here. They never talk, right? So what I do for the patient so this is my big thing at Health 2.0. When I went to Health 2.0, I would meet all these great patient-centered companies. These patients are over here, and they're doing fantastic stuff, and it's great stuff, and it works wonderful. But their output is something called a CCR, Continuity of Care Record. Well, you know what? Everybody on this side uses something called a CCD, a Continuity of Care document. They're both XML, but they don't communicate. I can't extract information from a CCR to a CCD. So fundamentally, my Health 2.0 companies can't communicate with the entities that they need to communicate. They need to be doing CCD so that they can merge and connect with companies. And until they do that, Health 2.0 is a tremendous company, but they really need to allow access and facilitate. When I sat at CCHIT is the Certification Commission for Healthcare IT, and it was used to be a government-run agency. It was a government-funded agency that rubber-stamped electronic medical records. They basically wrote, what we did is we wrote criteria to make sure that, does anybody have, let me hope I don't unplug my light here, but I'll show you this. Okay. You see this cord? You see this little tag on the cord here? Okay. There's an organization of engineers, okay, the IAEA, and electrical engineers got together, created a bunch of standards, and these standards were created that basically say, if I take this plug and shove it into the wall, I'm not going to electrocute myself. That's what this tag is. It's on everything that's electronic in the United States, okay? CCHIT was basically this tag for electronic medical records. So what CCHIT did is basically said, if you buy a CCHIT certified vendor, you know that if you plug it into your practice, you're not going to blow it up, basically. Stupid analogy, but that's basically the way it is. So this CCHIT, you know, what we started to do called harmonization. And harmonization is getting not only the patient side to communicate, but also the inpatient side. Another big miscommunication is the hospitals. So, again, I know I'm throwing a lot of detail at you, but if I'm a patient, and let's say I take Cozar for blood pressure, I take Loveza, and I take Doxepin for sleep, or whatever it is. And I go into the hospital because I break my neck, or I break my arm. I go into the hospital, I have to take my medications. They give me new medications in the hospital, whatever, and then they release me from the hospital and they change some of my medications. I take Cozar, Loveza, and Doxepin. Even though I get this medication list from the hospital, when I leave the hospital and I get my discharge summary, I can't take electronically my medication list of the same meds that I had before I went into the hospital. I can't take those meds and send them to my doctor electronically so that they have them and they know it's the same medication. They have to re-key that information in. That's stupid, but that's where we are. So what CCHIT was trying to do and what Health 2.0 is trying to do and what a lot of people are trying to do, ONC, which is another one for meaningful use, is they're trying to harmonize and get everybody to all speak the same language. That's where the innovation is. The innovation is we're all here, and we need these connectors here. We need, the innovation is going to come from somebody who figures out a way to not do HL7 to connect disparate healthcare applications, but a way to black box and basically have people connect in each side and have information flow the way that I want in a way that makes sense. Right now it's done via HL7, which is 1980s technology, and you know it's like rearranging deck chairs on the Titanic. In my opinion, true innovation is going to come from those innovators who can take the last mile, who can connect everybody together, in my opinion.
So I guess I want to follow up. Because you said you compared the U.S. health system to other countries, and you said the biggest difference is that the base start for other countries was a continuous system, as in they started with the system first, whereas America is a bunch of separated different systems, and what we're trying now is to connect them, right? So do you feel like, no, go ahead.
There's no system. I mean, if you think about it, there's nothing. There's paper records. You know.
So do you think the solution is actually a bunch of different innovators trying to come up with solutions, building, you know, their own small businesses, targeting small states or small groups of physicians or small groups of patients? or do you think the solution is actually the government stepping in and doing something? Because to me, it seems like policy is the thing that makes a difference right now. When you talk about when you talk about being on the board and making actual policies that help govern things, that's what makes a difference. Not somebody coming out and saying, all right, I have this new technology that's going to make a difference. At least that's where I'm seeing it. That if somehow we can come up with a group policy that the entire United States adopts, that's going to help influence or help facilitate communication better than a bunch of different high-tech companies coming out and saying, you should use my product. No, you should use my product. How about my product? Because competition isn't conducive to, it seems like at least, cohesive healthcare throughout the entire country.
I have a great answer for you. Take some time and look up something called Prometheus, okay? And honestly, Prometheus is the first, it is actually the very first pay-for-performance program. And it was called Prometheus. And what Prometheus was is basically a bunch of doctors got together from different societies and did just that. They said, we don't need anybody to tell us this is best practice. This is what you need to do to ensure that you're providing good quality care. And they invented this fantastic pay-for-performance. It was basically this whole thing that dealt with healthcare, and it was created by doctors and created by providers, and it was a wonderful altruistic gesture and everything else. And what you'll find is that you're absolutely right, but remember the second, if I told you to take two things out of the call, remember the second thing, where's the money? And you're absolutely right, but it's idealistic. You're right that it's really not going to come from the tech sector or anything else. The thing is, who's going to pay for it? The way that the American healthcare system is set up, because it's paper-based and there's no database and there's no requirement, and basically 10 years ago, if I was a doctor and I just wanted to use paper and I wanted to use a pegboard, I could bill my insurance companies and I could practice. There was nothing stopping me from doing that. So the thing that's important is you can create a program that does anything that you want, but unless it's paid for and unless there's a way to finance that, and that's where the Achilles heel, and that's how Prometheus failed. Prometheus failed is because the doctors created it, but nobody paid for it.
Right.
So I hear you, and you're absolutely right. But where I think the innovation is, and I don't think the innovation is going to come from a large tech company. I don't think it's going to come from a GE. I don't. I think it's going to come from a Health 2.0 company, somebody who figures out a black box that allows seamlessly to connect my stuff in and to do the data, to do whatever I want. Because really, 5 years ago, when I first started on CCHIT, there was no concept of something called modular certification. Basically, what CCHIT did is you had women's health, and you had to jump through hoops and prove that your software was good for women's health. It did a prenatal record that was based on ACOG standards and University of Oregon guide, all these crap that you had to do for women's health.
Right.
And you had to get the entire product. You had to buy the entire product from one place. That doesn't work. What we found out with meaningful use and with ONC and where we've evolved now and where Health 2.0 was, rightfully so, is now I need to be able to take disparate products from everywhere and get them to communicate in a common way. I need to link them together in a way that allows them to communicate information seamlessly across multiple platforms. SaaS or actually not software as a platform is really the next evolution. Software as a service, who cares? Software as a platform is really where things are going. But getting the ability to have disparate healthcare applications, so whatever your infrastructure is, getting that to communicate together, that's not going to be from a big guy. That's going to be from a small guy who says, why are you doing that? Why don't you do it? Not by mine, it's open. It's going to be open source. It's going to be, and what's going to happen is somebody's going to go, why didn't I think of that? But it's a big, but the issue is why that hasn't happened is because nobody's paid for it. And in this economy and the way that the United States healthcare system works, you do, from a business perspective, combine procedure codes and diagnosis codes to maximize reimbursement. You need to get money in. If you can't pay for it, you can't do it, if that makes sense. That's a bad answer, but it is what it is.
No, it's a good answer. Can I pop out for like 10 minutes and I'll be right back, Francis? Is that okay? Okay. All right. I will be right back.
No, you must stay. You must all stay.
All right. I'll see you guys in a bit.
Yeah, so I actually have to head out in a minute too. My ride is leaving. But basically, my one question was, could it be possible that there's a disjunct between the idealistic reflecting the physician's mind into data mining, into data storage, and the connecting and seamless integration of a database structure that can be adopted by all physicians? Because I feel like every kind of startup that I've worked with, especially software startups, especially internet-based software startups, they all say, oh, this is going to be cross-platform, it's going to be seamless, it's going to integrate. And that's kind of just it's something that is so valuable yet so hard to achieve that I feel like the only way to do it is to just put some kind of massive grand prize on. I mean, isn't this something that would greatly lower the cost of healthcare for everyone? Is there no reason for a government some type of competition? Or
there is, but the question then becomes, when it goes back to the money, and I get the money in there, where does the money come from? And if I'm providing you money, I'm not providing you money to help somebody else. I'm providing you money to help me. Yeah. So until I get a way to generate revenue from multiple sources to truly innovate, everybody's going to be like Epic. If you want to look at a big boy who's doing the wrong thing, I shouldn't say because it's such a huge company, but who have cornered the market, and it's what we call a surrender strategy, Epic. And Epic won't talk to you unless you have $10 million. If you don't have $10 million, don't even talk to them. And what they do is they do a holistic, they do everything. They come in and get, and it's cross-platform because it's their platform. But who is going to give that money? Well, CMS is giving the money. So is the money from CMS going to help me with Blue Cross and Blue Shield? Eventually. But today, they don't give a crap. They could care less. So what you need to do is you need to find a way, cross-platform and everything else, all the buzzwords, it's fantastic, but who's going to pay for it? If you have that, I mean, I'll tell you, when I would go to these Health 2.0 meetings, Francis and I and James Matthews would all sit together. They had the new technology innovators. And what we would do is we'd all sit together and we'd watch the presentations and we'd say, fantastic, but we'd all look at each other and say, how the hell do they make money? And if you couldn't figure that out, or where do they get paid? And the ones that couldn't figure that out didn't come back the next year. The ones who did figure it out are still there. And that's the thing, is that you're absolutely right, but until that money comes from multiple sources and in a way that's designed not altruistically, but if you can fund a model or fund a method to communicate that benefits not only the person who's funding it, but also everybody else, that's really where it becomes more complicated. So if you can get everybody to agree and fund it together, fantastic. And not have Congress do it, because when Congress does it, they enact something like meaningful use that doesn't do me any good if I'm an orthopedic surgeon. So anyway, I hope that answers your question.
Do you think with a decent marketing strategy and like a grassroots student campaign that we could possibly do something for this on Kickstarter?
I do. I think that actually the future of this is patient-enabled healthcare, and I think that if the patients drive it and the patients are creating a model of something that brings value to the doctor, and brings value to the insurance company. If you can bring value not only to your doctor but to your insurance company, a grassroots patient or patient-enabled healthcare, which is the whole concept of Health 2.0. But if you have the key is educating patients in a way and getting them an app or a piece of technology that allows them to bring value to their doctor. So Google Health, even though the business was fantastic because I could use it, bring it to my doctor. MedSimple, Francis' other company that he has, fantastic. You go, you put in your symptoms, it gives you a list of questions to ask. That's the kind of stuff. But it's definitely, if there's going to be change, it has to be from the patient side, because the patient is the center of all of it, right? They're the one who's having everything done to them. But the thing is, they have to bring value and money to the doctor and save money to the insurance company. And if you can find something that does that and market it and have a marketing strategy based on that and attack the physician side and the insurance side, you have something, and that's going to be the future. That's going to be the next billion-dollar idea. That's going to be the next Microsoft or Apple or whatever else, is the people who can market to the physician and to the insurance company in a way that makes money for one and saves money for the other, and also boosts your healthcare. It's easy enough for you to use so that you can, you know, do something with it, in my opinion. Next, anybody else? Have I numbed everybody to sleep?
Well, for me, I was just wondering, like, so it seems like there's no motivation for patients at all to communicate with insurance companies, but what ideas would you have for patients to actually want to communicate with insurance companies?
Okay, have you ever called your insurance company for anything? Have you?
Just asking, like...
No, I'm not being funny.
No, not really.
Okay, when you do, or ask your parents or ask a family member who's been through healthcare, when they call their insurance company, ask them what the purpose of their call was. And
just like the benefits that I'm getting or something.
No, it's a complaint. 99% of the time it's, you won't cover this. Why are you doing this? I'm standing in the pharmacy and you won't cover topical bleomycin for my planner's ward, so what do I got to do? You know, you're pissed off at them, right? So how do you interact with the insurance company? That's a thing that really, you know, what you have to do is if you have like I have hypertension, right? So I have a case manager assigned to me. My case manager nurse is aware of programs because I'm in the industry. I know about things that are coming and initiatives because if you as the patient call the insurance company and have a case manager know somebody there and say, listen, my doctor is so-and-so. Are there any programs that the doctor can participate in, help them get money that'll help me with my health? And if they'll say, oh, yeah, we have QHIP, you know, there's a program from Blue Cross and Blue Shield that nobody knows about called QHIP. You know, you bring that to your doctor and say, hey, doc, I found out this QHIP, here's this person's telephone number, give them a call. You know, and it's a program where you'll get an extra $10,000 a year for participating in this program and providing them some insurance, you know, some basic information, which they're already providing. But I mean, that's an idea of contacting the insurance companies because right now the only reason you're calling them is to bitch at them. Does that answer your question?
Yeah. And I guess my other question is, so if like doctors are getting paid to do things that like to use technologies or basically, yeah, if they do a certain procedure or something, so that's how they get paid. But why would they have any motivation to use better technologies? Because those technologies will probably make them cut down on using future procedures.
Well, because they're technologies and concepts that allow them to do procedures faster for less money and allows them to do more procedures or makes it easier to do procedures. So and also there's revenue there. So if there's surgical trials and clinical trials. I mean, how do new drugs come to market? Well, they have doctors who do phase 1 through 4 clinical trials or surgical trials. And the reason that they do it and they do new technology is because, and that's typically in the academic medical center. So an academic medical center will do this, but also in the outpatient market, you adopt new technology because it allows you to do your job better, faster, and easier, and gives you more money. Go ahead. Yeah, you had a question.
How much of this responsibility do you think we can shift onto the patients? Their time is a lot less valuable, and if we can make some type of system that actually validates what they're inputting into the program, connects that to the database, then maybe it saves time. Or I don't know. How much of the responsibility do you think could be shifted to the patient, basically? That's
a good question, and do you know the difference between a good question and an excellent question? Is an excellent question you actually have an answer for, but it is a good question, and actually it is an excellent question. The problem, and you're not going to like this, but the problem is the perception of doctors, rightfully so, is that patients as a whole are stupid. Patients don't understand. They don't understand the mystery of medicine. When a doctor asks a bunch of questions about history of present illness and what their process is, patients don't understand it. They fundamentally don't understand what the doctor is doing. They think when they go in, they tell a story. I was making chocolate chip cookies. I ran out of chocolate chips, so I switched to oatmeal. And when I switched to oatmeal, the phone rang, so I tripped over the cord, and a puff of smoke came out, and that's how I inhaled the yellow smoke, and that's why I'm here. They don't give a crap about any of that. You know, I mean, that's a typical, friends will tell you, it's a typical history. You got to say, all right, stop. I don't care about the fish and the oatmeal and this and that. Tell me what happened. How did you breathe the smoke in? What, you know, but teasing that information out. But patient, how much do you shift onto the patients? Until the doctor's perception of the patients is changed to the point where the patient is more participatory in their healthcare, I don't think you're going to, and it's going to require a whole series of doctors dying off, because quite frankly, the way that my dad was trained is not the same as how Francis was trained, you know. And I mean, my dad's going to have to die off, and I know better than you, you know. I mean, because right now, some of my dad's patients, if he gave them paper clips and take these 4 times a day, yes, doctor, is the only answer. They don't ask why. And there's a whole mystery of medicine, you know, getting over that perception and figuring out a way to have patients participate in their health care and make a difference and everything else really depends on the attitudes and prejudices of physicians and the way physicians are trained. And the only way that's going to happen is by the adoption of technology that is inclusive of the patient, not exclusive. Whoops, yes, I'm still here. All right. Sorry. Once technology is inclusive of the patient and the patients start to participate and doctors start to see that patients can add value. So, for example, a great place where patients are making value is with home glucose monitors. Patients with diabetes take their blood glucose, they put it into a machine. If I can upload that data into a personal health record and take that personal health record data and transfer it into my electronic medical record at the office, and that data is good and valid and helps me treat that patient, that doctor is now converted on that technology and will tell all of his diabetic patients to use it. Before you know it, all of his diabetic patients or all of his diabetic patients' kids, who are their caretakers, are going to start using the same technology because it uploads valid information into the electronic medical record. Right now, what they're afraid of is that the patient's going to type in that their glucose level was 900 this morning. Couldn't possibly be, you know, but if you can trust the technology, educate the patient, provide value to the providers, and get over that prejudice that patients are stupid, I think things start to change, but that's a big if. So is there innovation that can happen there? Is there a marketing strategy that can happen there? I think absolutely, but it's an uphill battle.
Yeah. You guys, thank you so much. Like, this was truly amazing. I wish I could stay. Francis, Estelle, thanks so much.
Anytime.
Bye, guys.
Email me any questions if you have any.
Will do.
Anybody else? Have I knocked everybody else to sleep?
My questions were already answered.
Hi, I'm Sophie. I'm a 4th year at UC Berkeley. Sorry I was late. I tried to get on BART, but 51B didn't pick me up at the station quickly enough. But I guess I just wanted to see what you thought about the situation with healthcare now, or actually the situation that's arising with healthcare, because I know that you mentioned, you know, a lot of the doctors need everything that they use in hospitals is really incentivized, I guess. And I feel like it's not only with technology, but it's just with, you know, money. Money has a lot to do with everything. I mean, I feel like healthcare now, even though there is not enough money to go around, that's probably why, like, money is so incentivized, and who doesn't want money? But you know, with the new healthcare bill that's been passed, I know that there's going to be a surplus of patients, and yet, even if not all Americans are under one healthcare now, there's still a huge gap between how many doctors there are and how many patients that they can attend to. And I was just wondering what what your thoughts were on that, and what you think is going to happen by 2014 when 350 Americans are going into hospitals, and yet it's still so hard for doctors to want to go into just a regular patient care, not even like specializing in anything,
Well, yeah, I mean, I have to say, I don't think things are going to change that dramatically on the inpatient side. I mean, when you think about it, the money that's there for the hospitals as an entity, that really rarely trickles down to the doctors who are on staff and everything else. I mean, they rarely actually get the benefit of that money. It really is more, they trickle it down in certain ways and they carve out payments and everything else. But as far as the number of patients entering into the hospital, I don't think the new healthcare bill is going to make a dramatic change from today. I mean, basically today patients use emergency rooms for primary care. I mean, they do it today, and they can't turn them away, legally can't turn a patient away, so they use emergency rooms in a way that they shouldn't. The question is how is there going to be a difference in payment? Is there going to be a difference, or are we going to be able to compensate that? And I don't think anybody knows that answer. I think the one thing that's great, because the first time in history is the federal government has enacted a program where they're actually giving real dollars, $44,000 per provider. So what that means is that if I'm a solo doctor, I get $44,000 for an electronic medical record if I implement an electronic medical record system that meets the requirements of meaningful use. Now, I should tell you that for a solo provider, if they get gutted to the studs and have an electronic medical record system put into their office, it'll cost them $60,000 or so. So a good not all of it, but a good portion of that money is recouped by that $44,000 money that I get back from CMS if I use an electronic medical record that provides the information. Now, if I choose not to, that doesn't mean they can't practice medicine. All that means is that by 2015, Medicare is going to reduce their payments by 4%. So if you can take a 4% pay cut, you don't have to use electronic medical records. That's totally fine. So I don't think there's going to be a dramatic shift because of the new, Obamacare or anything. I don't think that's going to make that much of a difference. I think that, when the real money so what's happening now is that small practices, solo doctors are disappearing. They're joining with larger and larger groups because remember that $44,000 per provider. If I join 2 other doctors, instead of $44,000, each doctor gets $44,000, right? So now, if I implement an electronic medical record for a 3-doctor practice, now I sent all of you a tool that I've used since 2003. I can't overemphasize how valuable this tool is in an ambulatory. I mean, this took like years to write this tool, this Excel spreadsheet. And what this does is this shows what a cost of an electronic medical record system is and their return on investment using an electronic medical record. EMRs, electronic medical records, when you get to 3 providers or more, basically the cost is somewhere between $25,000 per provider and $40,000 per provider. So somewhere between, for a 3-doctor practice, somewhere between $70,000 and $120,000 is what it would cost for an electronic medical record to be installed in a 3-doctor practice. Now, each additional, so by using that, if we look at meaningful use, the CMS program that's out there, $44,000 times 3 doctors, I've paid for the system plus some. But really, that tool that I sent you shows you if I add 100 doctors in there, it's the same ratio. So it's basically, if I have, it's somewhere between 20, if it's a group practice, which I define as 3 doctors or more, an EMR system, a holistic EMR system, will cost you somewhere between $25,000 and $40,000 per provider, depending on what crap you add to it. If you add DICOM and PACS imaging and all that stuff, it's closer to $40,000 per provider. If it's basics, it's closer to $25,000 per doctor. So using that metric, CMS is providing enough money for group practices to purchase electronic medical records and have money left over for training. So doctors are leaving solo practice and joining larger practices and having hospitals buy their practice. It's a big pendulum. Every 5 years, doctors go and they go back to the hospital and they let them buy their practice. And 5 years later, they all leave the hospital and join their own solo practice or whatever it is. And it goes back and forth and back and forth. And what drives that is the money. And it's the first time in the history of the United States healthcare system where the federal government is offering real dollars. There used to be something called PQRI, which is Physicians Quality Reporting Initiative, that reimbursed 2% of CMS receivables. Who cares? But now, at $44,000 per provider in a group practice, it's real money. So I think that's what really is making, at least that's what we're seeing, is making the difference. Now, the problem is that doctors hate it. They hate having to provide information to the carriers because the carriers, the insurance companies, are looking over their shoulder and telling them, you're not doing a good enough job, and I'm going to send your patients to somebody who is. And they hate that. So even though they're paying for it, they're pissed, if that makes sense.
Huh.
Probably not the answer you wanted, but.
Oh no! But so, do you think that would? So that is good. I mean, it would make the quality of care a lot higher than it actually is now. Is that what you're?
That's the intent. I got to tell you, I'm not so sure about that. I think the one thing that did improve quality is there are 98,000 patient deaths per year for patients for medication errors. Okay, e-prescribing and CPOE and medication checking has the potential to reduce that number by 2/3 or more. There's value. There is an ability to improve quality patient care, and that's what the insurance companies, and that's what these reporting requirements, what they call P for P, pay for performance, that's what the intent is. The intent is to raise the quality of care so that you are actually providing better health services to patients. Doctors, unfortunately, don't see it that way. They see it as, we know how to take care of our patients, you're basically stepping on my toes, get out of my office. But if they want to get paid for it, they have to do it. So it's a tough environment to sell in, and it's a tough problem to fix. But it's there are companies, there are innovators out there. So in my industry, eClinical Works came along, and they were a market innovator. They shook up the market. We charged client server installs, like I said, 25,000 to 40,000 per provider to implement a system client server in the office. eClinical Works came along and said, I don't give a crap about your infrastructure. As long as you have internet connection, I'll charge you $299 a doctor. You can connect on the internet and do it all day long. And they completely disrupted the market and threw us all for a curveball, and they ushered in software as a service, or the ability to have products like Practice Fusion or any of the EMRs that are SaaS-based, or what they used to call ASP, but basically the ability to connect to over the internet. And then, originally Medisoft and Lightech on the practice management side were entry-level billing software. Now they're $5,000 and $6,000. Nobody can afford it. That opened the door for companies like Cario. Cario came in, and for $200 or $59 a month, you can access on the web and do your billing on the web. It's so there's innovators, and there are people who come along and they shake up the market and they change the way that the business works fundamentally. Hello.
Hi.
Hey, what's up?
I'm Lewis.
Hey.
Just moved in.
Sabrina.
Oh yeah, I talked to you on Facebook. And
yeah.
I'm just wondering if I can take one of those.
That's Lewis. Lewis is talking. Yeah. Sorry. That's right.
Okay.
That was fun. Okay. So what was it?
Constantly muting her. Feels so bad.
Yeah, but the point is that there are innovators who come along and completely change the way that the industry works. And the areas where the industry is changing now is with patient engagement, patient-enabled healthcare, and the attitude of the doctors has to change. But frankly, it is changing. And the way it's changing is from multiple sources, from having this EMR shoved down their throats, but they're still missing the ball because they're not involving the patients. Well, as soon as they start to involve the patients and patients get less stupid and they start to provide value, I think things are really going to change. And in my opinion, that's where the next area of innovation is going to be. is having non-stupid patients and non-stupid patient. So you guys are all perfect age, right? So your parents and grandparents wouldn't get out of the electric chair to use a computer to manage their healthcare. You, however, would. So you know what? You will go to Google Health. You'll go to Microsoft Health Vault, and if you have a sick parent or a sick grandparent, and you become the caretaker, you will create you'll gather all their MRI reports and all their images and all the things they need. You'll scan them and keep them on a computer system or on a website so that you can access it and help provide health care for sick and elderly parents or grandparents. That's where the future is, and that's where the innovation is. So Francis and I talk about this for hours and hours and hours, but the bottom line is that's where I think the next innovation is going to come, is not with because my mom, my grandma wouldn't get out of the electric chair to touch this stuff, but I do it, so I help her get to a doctor's office because I scan in all of her records. I use Google Calendar to know when her appointments are, and I have everything attached, so when I go to the neurosurgeon because she had a back tumor removed, I can go and bring up all of his images and show the last time he did it and look at all of them, and I have them all on my fingertips. I won't do it for me. Who gives a crap about me? But I think that's really where the future is having caretakers the ability to create personal health records that bring value to the providers. Because right now you go, you don't show up, you don't have anything, they don't know what the hell to do with you. So it's the education of patients and the re-education of doctors to believe that patients are not as dumb as they think they are. And that's, in my opinion, where innovation is going to be.
Can I ask what you think about a particular innovation?
What?
So you're familiar with Francis's Med Simple?
Oh, sure.
So imagine that a patient could fill that out himself or herself before stepping into a provider's office.
I do.
And then having software that performs analytics on that data and then blurts out like the top most likely diagnoses and then the accompanying costs of those diagnoses. Do you think that would be valuable even to insurance companies who want to use that as a reference to make sure doctors are doing their job well?
They do. They already have some stuff like, there are some people who are innovating in that area. Yeah, I mean, I use Francis's application all the time. I called him about it because I had a problem with it last week. But it absolutely is. I mean, I think there's tremendous value there. There's actually an Irish company that I met at Health 2.0 in 2007, and they do something really cool for the insurance companies, and they market to insurance companies. What they do is they have a list of questions that they ask the patient after the visit. So in other words, let's say I go to see my doctor, I use Med Simple, I fill out my HPI, the doctor does everything, does all the analytics. At the end of my visit, I get an email from this company based on the visit that asks me 10 questions, and those 10 questions go back into a measurement device that tells me with 95% accuracy or more as I use it whether or not I'm going to be compliant with a treatment regimen. It'll basically tell me psychologically, and am I going to comply? Am I going to be somebody who needs to be handheld or something else? So there are some rudimentary. I think there's tremendous opportunity in that area, but the insurance companies are already thinking about that, and they're doing it today. If that makes sense, But I agree, there is tremendous opportunity for that. There's a company in New Jersey, Robert Wood Johnson University Medical Center, and they did this program. We couldn't figure out how they made any money, but it's fantastic. And basically what it does is it monitors texting, and it monitors for words that are negative or positive. They have a negative connotation or a positive connotation. And it basically analyzes teenagers for how mentally healthy they are, and it identifies patients who are high risk based on the types of words that they use at certain times of the day. It was a fascinating presentation. Amazing technology. We have the ability to get behavior analysis into healthcare environment. The problem is how do you monetize it? We don't know. Remember that one, Francis? Do you remember those guys? It's cool. Yeah, exactly. I mean, it's cool. Yeah. Yeah. Yeah, like have like sex and age. It was fascinating. The thing is, how do you make any money? You know, but I mean. But I mean that's my first thing that I said is second thing I said, where does the money come from? And if you can monetize your idea, and if you have a clear idea as to who's going to pay for it, you'll be successful. Now the thing is, if the patient's going to pay for it, it better bring a shitload of ease of use or improvement to their life. You know. There are plenty of free programs out there. The problem is that they don't dramatically improve my life. I'm not going to pay for something that I can get for free that doesn't, unless it does something to me that's fantastic. So if you want the patient to pay for it, that's great, but it's got to be marketed in a way that brings tremendous value in a way that they don't have it today. Or to
sorry. I have a question to kind of follow up. So you said that two of the biggest takeaways is combining procedures to maximize reimbursements, right? So I feel like reimbursements are influenced the most by policy. So would following policy really help show where the future of reimbursements would be? Because right now you say that for each code, for each procedure, there's a certain cost or certain dollar sign that's attached to it. So if you were to look, I guess, at reimbursement-based firms, you would be able to tell in the future if their cash flow is going to increase or decrease based on if reimbursements are going to increase or decrease. Do you think that makes sense? So, like, basically, if you wanted to project into the future and see which companies are going to be successful, you would want to look at where the reimbursement trends are going to be.
Well, and you're absolutely right, and that's actually what a lot of companies do. I mean, if there's something called an RBA, an RBM, radiology benefit management company, that does nothing but that. It basically looks at reimbursement strategies for imaging studies. That says, you can order something that's a lot less money that's just as diagnostically significant. So, I mean, they do that kind of stuff, but I'm not sure I agree with the premise that policy drives reimbursement, because the reality is that CMS creates a fee schedule that says, here's what you're going to get paid. There's policy that kind of decides whether or not you're going to combine certain codes and everything else. But really, there is a fixed fee schedule and you know that if I do this procedure, I get this amount of money. So the policy can change, and they maybe won't reimburse that, or they'll reduce that on a yearly basis from one thing to another. You just figure out a different way to change it. But yeah, I think if you can, and insurance companies have lots of ways to do this with third-party benefit managers, radiology benefit managers, TPAs they call them for the HMOs. But basically what they do is they do cost analysis and revenue analysis and try to figure out where the trends are and who's making the most money and costing the least amount of money. So, for example, surgery centers, right? So, in other words, why would I have an appendix out in a surgery center versus a hospital? Well, because a hospital may cost 5 times as much as if I do it in a surgery center. Well, a surgery center provides metrics to the state and to the insurance company that says Dr. A uses 10 pieces of gauze versus Dr. B uses 7 pieces of gauze, and two scalpels versus 5 scalpels. So they do a cost-benefit analysis, and they figure out who does the same procedure with the best outcomes, and whoever has the best margins, they push all the patients towards them. So they do complex financial analysis all the time. Is that answering your question? Or
yeah, no, that definitely helps. I guess because you know Julie, right? Julie Merchant.
Julie Merchant is very well. Brilliant woman. Brilliant.
Yeah,
brilliant.
I work with her. I work close enough with her at Health Evolution Partners. So it's a private equity firm, and they're trying to invest in healthcare firms. And I guess one of the outlets that they were looking at is comparing reimbursement-based firms to non-reimbursement-based firms. So I guess they're trying to decide, is it better to invest in firms that rely heavily on reimbursement, or is it better to invest in firms that rely heavily on, I guess in your terms, like patient or consumer, money or cash flow? So I guess, would you say that in the future, like the next 50 or however many years, companies that are relying on consumers are gonna grow fast, or is that like a growth area, or would you say companies that rely on insurance or government to reimburse would be like a high growth area?
Well, I'm not ducking the question, but that it's like apples and creme brulee, right? So in other words, the where the money's coming from, if you're looking to invest in certain companies, I think the ones that do control costs, that's what I do. I work for a company called Cognolink, and basically I advise financial companies who want to invest in healthcare firms. I tell them who the market leaders are and what they do, and we do. We talk a lot about if you have companies that use third-party administrators or radiology benefit managers, they actually have an ability not only to control costs but predict with much less volatility what the cash flow is versus something else. If you look at something that doesn't use that, like an orthopedic, so let me use a very simple example. Okay, so it's a little bit more complicated than this, but to give you the idea. If I'm an orthopedic surgeon and I do workman's comp and auto accident PIP type stuff,
Okay.
I'll see a patient and I know that the auto accident litigation case may go on for 15 years. So I see a patient today, but I don't pay it for 15 years. And I know that, right? So, I mean, would I invest with a company like that? Because my cash flow may come in, it may not. I don't know. It's 15 years out, whatever. Versus if I'm a surgeon, right? If I'm a general surgeon,
Right.
if I remove this appendix, I get $500 and I get it next week. You know, I'm much more like, it's an overly simple example, but I'd much rather be a surgeon who removes appendixes than somebody who is an orthopedic surgeon who deals with car accidents and law firms. Even though my payout may be bigger, there's a lot more volatility. It takes a lot longer to get paid, and it's a much longer cycle, you know, versus a regular surgeon who actually does something. It's fee for service. They do something, they get it. They do something, they get it. I do something and I wait, I make it a bigger payout, but I may not get any payout, or somebody may die, you know, so there's a whole bunch of stuff that goes on. That's essentially the question. When you're looking at for a company to invest in, do you invest with a company who, I would always invest with a company where you know exactly how many days in AR, accounts receivable, you have. So in other words, the time value of money, right? If I borrow $100 from you today, right, it's worth $100. In a year from now, it's worth 20, right? You know what I'm saying?
Yeah.
Okay. So same concept. You know, I mean, you definitely want to go, in my opinion, with the companies where even the cash flow may be less. If you know that it's coming in and it's less volatile, you have a much surer thing. Now, it's like the options derivative, right? I can go with the other ones, but it may take me longer, and I may get it, it may not. The payoffs. You know.
I suppose that's actually a pretty good answer, just because all the large private equity firms, for instance, Bain, or the ones that we've heard of, they all invest in the firms that you described, which have steady cash flow because they rely on. Yeah, I know. It's a smart move. Okay, I mean that answers my question. That was a good answer.
You know, I mean, finding the innovator. You know, you got to find companies who are willing to deal with innovators, like Health 2.0. Right?
Yeah.
So there are places out there, private equity firms, that will invest with companies who have great ideas. They're going to be restricted to Silicon Valley, and some other area and everything else. They're going to be very specialized. But most of the time, you're going to stick with what you know.
Right. Okay. Thank you.
Yep. Anybody else? Oh, yeah.
Basically having information right there in the cloud for access to what you need and also where you need it. And also the population of patients also getting smarter as this generation comes up. So how do you think having health has something to do with having information becoming more accessible
Well, I'll tell you, that's an excellent question. I mean, I think that the reality is tourism medicine. Okay, so tourism medicine I love it. I've been involved with it for years. It's fantastic. Okay, so let's say I work for GM, okay? And when I work for GM, I need a knee replacement, okay? In Atlanta, Georgia. I don't live in where I live. I live in the Jersey Shore, okay? So not the ghetto Jersey Shore, the place where Bruce Springsteen's from, right? So GM says to me, they say, okay, you need a knee replacement. We approve it. You can go to NYU or Monmouth Medical Center or wherever, and you can get your knee replacement. We'll reimburse you 50% of the cost of the knee surgery. You'll have to pay 50% out of pocket, and we'll give you 3 weeks convalescence to get back on your feet and come back to the office. We'll pay 50%. So the average cost is about $180,000. So you'll be responsible for half of $180,000. We'll do that, or we will send you to a 5-star resort, Michelin star resort on the Arabian Sea in Dubai for 1 month to a JACO certified hospital staffed entirely by physicians from Yale and Harvard who will perform the surgery. You'll have 2 first-class round tickets. You will have a month paid vacation at a 5-star Michelin star resort, and you'll have a month off, and we'll pay 100% of it. Which would you do? That's what medical tourism is. Medical tourism basically is the ability to go and have this JACO certified hospital, and then I connect it electronically. So when I do my surgery, I have my DICOM image, I have my op notes, I have everything else, and I send that information back to the primary care doctor and say, here's the image and everything else. So it's just like having it done here, but I have a month-long vacation. There's other types of medical tourism, but that's the big medical. When we think about medical tourism, that's one of the ones that you do. You go to places where healthcare is less expensive. You pay for it because it's a tenth the cost. I mean, why wouldn't you do it? If it costs $180,000 here and it costs $20,000 to do it, in Cochin, India, why would you do it here? And if it's a JACO certified hospital and all Yale and Harvard educated physicians and nurses, why would you not? So that's basically what the whole concept of medical tourism is. So I'm sorry. Guide me again towards the question that you were asking me. Well, I'll tell you, telemedicine is a fascinating field. The problem with telemedicine is that right now it's extremely expensive to do good quality telemedicine. So right now, the University of Georgia is really big with telemedicine. What they do is they ship out this, it's a monitor. It's like this big. It's got a high definition camera. It's got a blood pressure cuff, a thermometer, a breathing tube. Who cares? And what happens is they basically send this out to you. You plug it in every day, and you interact with the doctor over video or nurse with a web link. They check your blood pressure and your temperature and your pulse ox and all that stuff, and they basically treat you. The problem is that this unit costs about $10,000. So they ship it out, you send it back, you drop it, whatever else. But most people can't afford to do that. I think with the advent of the smartphone, because I'll tell you, 75% of the world, you look at Voxiva's business model, right? Voxiva, 75% of the world has a cell phone, right? In places where you don't have internet access, right? In third world countries that are, that don't have running water and everything else, everybody's got a cell phone. So having the ability to connect and do different add-ons to my iPhone or to my BlackBerry or whatever it is, and not only biometrics, but having the ability to capture information, send that information using apps in the cloud and get access to that information. As that comes out and becomes available and becomes more cost-effective and diagnostically relevant, right? If it's diagnostically relevant and I can have that information. You guys probably don't know who these guys are, but Biolog is an Australian company, and the space shuttle guy, actually everybody now on the space station now, Biolog, it's a unit about this big, and what they do is it's a 12-lead EKG that gets transmitted over a satellite, or it can be an analog signal, doesn't matter. But basically you wear a vest, or you put the leads on, you connect it onto this Biolog unit, and it sends that information out. So actually the astronauts are monitored 24 hours a day using Biolog units. They do a 12-lead EKG all the time, sleep with it on. If I can put that onto a smartphone and wear a vest that I can change from patient to patient and send that information to a cardiologist somewhere, fantastic. I have the technology to do it. Nobody's done it, but I mean, why can't you? If I can do it with a biolog unit, they actually have a PC-based one where you can put it on. It's a software. You basically put it in and connect it. There's a card you can plug into the back of your computer, and it'll do a 12-lead EKG on any laptop. You know, having that kind of information and expanding that to other sides, as the healthcare cost, as the costs come down to create these apps or products and services that interface with smartphone technology or laptops over the internet and cloud with cloud computing. This right now, you look at like so that's kind of a little bit future stuff. But let's look at what's happening today. Radiology with PACS images and DICOM today, right now, there are companies in the United States that basically have these images. They go up to the cloud, and they have doctors in India or Pakistan or wherever in China reading these radiology images online. They can do it from anywhere, and they read it right now. They send the radiology report. It gets sent back in real time. And you can look at it from anywhere. There's no reason in the world with DICOM images why I can't look at my images and read those images from anywhere on Earth. And you can do that, and they do that now. They outsource that now. Several hospitals do that. Johns Hopkins just rolled out a really big DICOM imaging on cloud piece where if you have access, you can get all your DICOM images and all the data that comes along with that. Because it's not only imaging, but it's the data piece that's there. And as we find ways to parse that data and submit that data and analyze that data, that's where the real future is, and bringing that cost down. Right now, telemedicine's expensive because it requires specialized equipment, specialized places, and heavy-duty pieces of equipment. As I migrate it to something like this or to a laptop or something that I could just plug in software or whatever, you know, that's really where telemedicine is going to take off, and it is. There are certain radiology it's already here. I mean, radiology is, I'd say, I don't know about 50%, but I'd say certainly 30% is done overseas at this point. You know, you can look at it today. You know, next could be dermatology or you know, anything that requires diagnostic pathology. There's no reason in the world why pathology can't be done someplace else if you're looking at images digitally. So once that happens, and you have a flood of apps that come out that allow you to do that kind of information, I think there's going to be a real change because actually telemedicine is reimbursable. Today, I used to, back in the day, I worked my way through school managing a trans-telephonic cardiac laboratory, and what we did is, you know, a Holter monitor is something that you put on and you wear it for 24 or 48 hours and it measures your heart rate. So for 24 hours, it does a rhythm strip. So basically, if you have PVCs or an abnormal heart rate, you see it, right? If you can't catch it in the doctor's office. So you wear this thing for 48 hours. Well, what if you wear it for 48 hours and nothing happens? They do something called an event recorder. And an event recorder basically means I carry it around with me for 3 months, and every time I have heart palpitations, I put it on my chest, I press the button, I call an 800 number, I listen to it over the phone, it translates that wave signal into a rhythm strip. So that's reimbursable. Medicare reimburses, I don't know, 150 bucks for that. That's today. You know, if I could do a 12 lead and do a full interpretation with a cardiologist, fantastic. You know, I mean, that's really, I think, where the future is. But again, it's all predicated on the idea that it gets onto a common platform or a more accessible platform to patients, and that the information is clinically, biologically relevant to the providers. I know I kind of circled around that answer, but hopefully I answered it. We're good? All right, if you ever have another one anytime. Yep. If you guys want to call me, email me, send me an email. I'll answer any questions as best I can.
Oh, can I ask a quick clarification question about Prometheus?
Sure.
I haven't had much luck Google searching it, but I was wondering if that Prometheus solution was the black box you described, where doctors could interface like any type of data and send it to it, or if it was like an entirely different platform that a bunch of doctors got together and tried to create.
It was what here. Let me hold on. Let me tell you what I would look at. Yeah, it's a platform that doctors created to. Hold on for 1 second. Let me stop talking for 1 second. Yes. Okay, here we go. Okay, so what Prometheus it was the very first pay-for-performance program that was developed by doctors. Okay, so all these doctors got together. So what you want to do is you want to type in Google Prometheus pay for performance. And here, I'll email it to all you guys. I have it right here. And what Prometheus did is it's basically a program created by doctors to provide better health care to patients. The problem is the doctor created. Well, the doctors don't pay anybody. So even though they did all this wonderful stuff, no insurance companies adopted it. So because the insurance companies didn't adopt it, nobody cared. So they never adopted. So even though it was this wonderful program, no one ever picked it up. No one ever paid for it. So it just kind of died on the vine.
Okay.
I'll send it to you right now. I'm sorry. Go ahead. What was the other? Any other questions?
I mean, I don't know. So the idea of that black box solution taking data from any party. So the hard part isn't the technology per se, right? It's coming up with that business model, how you, number one, empower the patient, number two, how you bring money to the doctor's office, and number three, how you reduce costs for insurance companies. But it's not as though like the technology isn't there, or it's like too huge a project.
Here's the fundamental problem. The fundamental problem is that the black box technology is there, but is to implement it. There's no one black box. The only thing there is something called HL7, Health Level 7, and that's a way for healthcare applications disparate healthcare applications to communicate with one another is via HL7. The black box technology, basically all you would do is you'd use something like Cloverleaf or some intermediary to basically say, using HL7 as the language protocol, field 135 on my software correlates to field number 2 on your software. The problem is that there's no industry standard. Nobody says this is the black box you use. So if you plug into this, everybody has their own black box. So GE created its own black box. So if you want to connect to GE, you would basically have to write your APIs or write your connection to GE. But GE doesn't have to do anything to connect to anybody else. Somebody has to do the work. It's not like plug and play, because even though I have this HL7 is basically, it's a table, and then how I connect that table is a manual process. That manual process is this black box. Getting that black box so that everybody agrees and says, yes, let's use this black box. Nobody has an incentive to do that, because everybody wants you to use their own black box, because nobody wants to do the work. Because the bottom line is it's a ton of work, and nobody wants to do it. If that makes sense, Yeah, if you guys want to do another one, if you think of anything else and you want any more help, I'll be happy to help you anytime. And tell Julia I said hello and all my old friends.
I guess I just want to ask something really quickly. So you're saying that a bunch of independent groups have their own standards, right? And the problem is that nobody wants to conform or change their standards to match other people's, and that's because it takes so much work. So that's why everybody has their own standards. So is the solution? Wait, sorry, yeah, go ahead.
No, yeah, you're right.
So is the solution to find a way to translate standards from one to another, or is the solution to have everybody try to adopt the same standard?
I don't think everybody's ever going to adopt the same thing, because there's no incentive. There's no incentive. If you could invent an incentive for everybody to adopt the same thing,
they would have done it already.
Sorry?
I'm saying if there was an incentive, they would have done it already. And the reason they haven't done it, yeah. So I guess what you're saying, the black box, is basically some third party, some innovative group who can find a way to translate standards so that different parties can communicate effectively. And that group has to do it through like some innovation in IT health, right?
If there was like a spider engine that could crawl into each database and take a look at the database schema and basically match up and say ICD code is field number 562 in this software, and I found the same field as number 2 in this software, and in this other software is number 3. And if there was a spider that could go through and identify those and match them together seamlessly without human intervention, that's really what is the only thing that will work.
So that's the black box you're talking about.
That's the black box.
Yeah, whoever can come up with that one, I guess, program that can do what you just said, which is go through it.
Or that could ask questions, that could say, is this? Do you mean this? If it could guide you through that and connect it.
That seems impossible. That seems crazy.
Yeah.
To do it through so many, I mean, I don't know that much about the limits of coding and technology, but that seems like a lot of work, I guess. No, right, Sabrina? I mean, I'm just trying to think of it, and also getting all the different parties to agree to do that, because the whole idea in the end is there has to be some monetary incentive. I think, at least that's what I'm getting, right?
Yeah,
and why would people do that, even if you could come up with something like that?
I mean, you look at Epic, or you look at Kaiser, and why would Kaiser create a black box to connect to somebody else's healthcare application?
No, exactly. Like I have Kaiser right now, and I'm using Kaiser's online system. I just scan my immunization records into them, and I don't see any reason why Kaiser would want me to be able to share that or get integrated with some other healthcare system. They just want me to stay with them and want me to use their system, right?
Right, but what you do, yeah.
Continue. Just want to let you know.
Oh, okay.
Hi, Sophie.
Anytime.
Okay, bye. Thank you. Thank you so. It was very very engaging and informative. I mean, yeah, I wish I could stay longer, but I have to. So, all right, bye. Thank you, everyone.
Yeah.
See ya.
Yeah, Ivan, you're absolutely right. There's the new information, right?
There's none. There's no. The only incentive you have, the only way to get it started, is with the state. So Kaiser, you tell Kaiser that you need to share the immunization registry information with the state that you live in, the state of California. And if they can share that information into the state registry, and then the state can share it with somebody else. Once you get the ball rolling and you get it into a common format, then that's what the whole concept of something called CCD, CCR, continuity of care record, continuity of care document, or continuity of care record, continuity of care document. They're all called CDA documents. And if you have it in a CCD document file, once you get it into a CCD, it's consumable by other entities, and that's really the key. So Kaiser doesn't have an incentive to do that, except with the state, because the state requires it. So if the state requires it, and then you can get the state to produce a CCD, which you can, that then becomes consumable. But then the question is, how do I get that information from the state using the privacy laws that prohibit the state from sharing patient information because it's all de-identified? So you have to opt in and bring the patient back in to allow, so the patient can opt in and specifically allow their immunization data to go through, but it involves the patient, which requires a technically savvy patient who understands the ramifications of sending their information from the state to other entities. And then, so let's say my record and my immunizations go there, my health record goes there, and I happen to be seeing a psychiatrist because I have manic depressive disorder or whatever it is. Well, I want to share everything with everybody, but I don't want everybody to know that I have depression, so I choose to opt out of that, and I don't want that sent. So how do I manage that? How do I manage who gets what, and how does this? So it becomes so complicated and involving the patient, but the patient has to be savvy enough to understand and pull information out. And then if I share that record with somebody else, what do I tell them? If I chose to hide something from the record, and what we came up with at CCHIT is you need to tell the doctor, this record is different from the original record. You can't tell them why, but you can say it's different from the original record. Well, now that I have it, I don't know why. So is it relevant, and is it clinically relevant? Can I use it? I can't because I don't know what the original change was. So
Yeah.
I mean, I know it makes your head spin, but I mean, this is the complicated. And what you can always do is you can take your samurai sword behind you, or the and you could just cut them up if you want from there. Your samurai sword.
That's a pretty big problem.
Right.
Privacy is something that's like gonna nearly be impossible to make people understand, or I just get around, I guess, because yeah.
I mean, I believe the key or the secret to the future of where we're going to enable healthcare or where we're going to enable patients to become educated has to do with them as caregivers for their elderly parents and for their children. So I believe that there's a sweet spot of people who are either still in school, who are going to have elderly parents who are going to need to be taken care of and have complex medical care requirements that can't do it themselves. If you come in and manage all this stuff and create a personal health record for them as their caregiver, you then will show value to the doc. So I think that's what's going to bring the tide. I think this focusing on that and allowing a personal health record, not for yourself, but for you to act as a caregiver to those around you who need it or require it, you're much more apt to be compliant, you're much more apt to be complete, you're much more apt to opt in and understand the risks, and also have the benefit of sharing that information. Because right now, if any of you went to your parent's doctor or your grandparent's doctor, you would have no idea what you could do to help them. No idea. But if you had their records and had all their history on a thumb drive or on a website that you had access to, all of a sudden you have the ability to really affect change and save their lives. And I think that's where it's going to be the difference. Not with ourselves, not with anything else, but I truly believe it's in that scenario where we're going to affect change, and where the money is. I think that's where you'll make the money, right? Because you talk to moms, nervous first-time parents, get the immunization record for the kid, they'll jump at it. They'll pay you $20. They'll pay $20 a year to maintain that. Absolutely, I would. Or something like that. I mean, it's simple, it's a stupid example, but I mean anything like that. Anything that I can do, if I can manage that information, what am I willing to pay? That's where you should do, like an IDEO. Do you know what IDEO is?
No, what is an IDEO?
IDEO, they're the guys who actually invented the iPhone. People think Apple invented the iPhone, but IDEO invented the iPhone. IDEO is one of the creative companies that actually works with Apple to push concept.
Wait, I know IDEO. They're headquartered in Palo Alto?
Yeah.
My friend was part of that when they. Oh my God. Okay, I told you IDEO. Okay.
Yeah, IDEO.
I told you when you said IDEO, I thought you meant IDO, like the letters.
No.
But then when you okay, all right, yeah. Okay, I should go then.
Okay, so those guys. I mean that's where, in my opinion, you guys have a tremendous ability to affect change and really do a grassroots, because you do an IDEO presentation, and I used to do them all the time. You do a group analysis where you get a group together and you have some sticky and basically have business problems or things that you want to solve. And the power of the group coming together and giving you ideas, that's where your innovation will come from, is using the IDEO strategy to develop products and everything else. Is what's the problem you're trying to identify, and break them into groups and have them identify and work on different problems. And you don't squash any creativity. But basically, however crazy they want to make it, you bring it together and you do that stuff, and you'll come up with a solution. Because what you'll find is that every student health, I mean, perfect example. I mean, you guys going to student health and everything else at the college, having the ability to keep all your records and medication, if you did any medications or appointments or anything else, anything they wanted to keep on there. You have all that information available to you and carry that around. You actually have the ability right now where you are in college to get a tremendous amount of feedback and an idea of what the people who are going to be buying in 5 to 10 years will buy. You're in a tremendous place to do that.
Damn, that's a lot to think about. Okay. Well, it is. It's
Yeah, I mean, there's plenty of great ideas. I would strongly recommend you go to the Health 2.0 Accelerator, and look at some of the companies that are there. If you want to email me, I can tell you, I mean, I'm not pregnant, but when I used to run women's health, at Medical Manager, I actually put in text for baby. I put in a due date, and I got all the free text that you can do it in Spanish or English, and it's fantastic. I mean, text for baby is amazing. And there's text for health, there's text for diabetes, there's text for sugar. It's a really great program, and it's free, and it'll teach you what's out there and what's possible, and then from there, understanding what a need is for not only you, but your folks and that kind of thing. I think that's where the true innovation and where the next big round of money is going to come from, is with these patient-enabled products that bring tremendous clinical value to the providers, reducing costs to the insurance company, and empowering you to capture information that is easy to capture with a good UI that's clinically relevant. It is what I don't know what Francis thinks, but that's what I think.
I guess I'm just a little. I guess I'm just a little confused. So, like, say I'm a caregiver for my elderly parent, and I have my parent's health record. Like, what else do I need? What other tools do I need to make that extra step where I can actually save their lives?
Well,
don't I still need, like, I don't know, something to tell me that, like, this is what I should do?
Okay, no. Okay, so let's talk about my mom. Is 69 years old. She had she was losing feeling in her legs for several months, and finally got an MRI, and it showed that she had a meningioma that was occluding her spinal cord. The 8-inch meningioma had probably grown for 20 years. So she had an MRI done that showed that she had this meningioma. Now, in the meantime, in addition to the meningioma that she had where she was losing sensation in her legs, she had to go to a neurologist. She also has hypertension. She also had a CABG. She had a 5-vessel CABG, a coronary artery bypass graft, several years ago. And she also had breast cancer as well. So so imagine the paperwork. I had MRI results. I had chemotherapy results. I had tumor results. I had PET scans. I had MRIs. I had X-rays. I had medications because the medication she was on included Neurontin. She had 15 to 20. She currently takes 30 different medications as well. So let's just focus. I could get more complicated, but let's focus on the medication piece of this. So now the medications that she got from the gastroenterologist, the neurosurgeon, the neurologist, the cardiologist, and her primary care doctor as well for hypertension as well. So she has all these 5 different doctors who've provided her with 30 different medications. Now her blood sugar's off, so the primary care doctor sends her to the endocrinologist. She goes to the endocrinologist, and because I had her health records, I brought up all the medication she had. She doesn't pull all 30 bottles of pills with her to the doctor's office. I have a list of all 30 of her medications. By bringing that list and showing it to the endocrinologist, oh my God, I almost gave you this medication. If I did that, it would have interacted with these 2 medications and I would have killed you. Thank you for bringing that list. That's the simplest example, but I mean, there are hundreds of others. I mean, in kids, the immunization status. When's the last time you had this? When's the last time you had that? You have the ability to check that information. So from a caregiver perspective, when you save lives, medication list is the simplest way to do it. But having access, when you go to the cardiologist, another way. I have every EKG she's had for the past 7 years. So every yearly EKG I have. So I see she had inverted T waves last year. This year she doesn't. She had PVCs 2 years before. Now she doesn't. She was in trigemini 4 years ago. Now, So there are many. So whenever you go, they want to look at comparative. They want to do comparative analysis. How did you do before? I have the ability to provide that information, and then in addition to that, health records, I use the calendar because she goes to 5 different doctors. So how do you manage going to the neurologist, neurosurgeon, cardiologist, internal medicine doctor, endocrinologist, and gastroenterologist, and OBGYN? How do you manage that? With a calendar, I mean, I can't do it on paper. You got to do it on a calendar, So just those are some very simple ways. And then keeping her insurance information there. So I know what's on formulary, what isn't. So when we go to the pharmacy, I know right there I can put in, check, that's not on formulary, however these drugs are. So these are just a couple of examples of that, but there's many, many ways that having this information is helpful, and you don't have it today. And right now, I guarantee you, if your parents or your grandparents go to the doctors and they say, what medications are you on? It's either Xanax or Zantac. I'm not sure. It's something like that. Well, which is it? It's a really big difference. And stuff like that. It's simple, stupid stuff like that, but that's the stuff that saves it. Does that make sense? Is it clear?
Yeah, that makes sense. It makes me curious for MedSimple. I guess, Francis, this question is more directed to you. Like, do you envision that MedSimple prototype to be used for everyday people? Because I always thought it was meant to be licensed to providers to use.
Let me tell you how I use it. Can I answer that for you, Fran? I'll tell you how I. Okay. I use it for my mom and I use it for me. Okay. What I do is when I go to the doctors, I typically forget 10 questions that I need to ask. So what I do is I go to MedSimple. Matter of fact, I have to go to the orthopedic surgeon tomorrow because you can't see it online. Well, maybe you can. Can you see that bruise that's right here, and also on this side down here? I was carrying something and I hit my arm and it actually exploded some blood vessels on the inside of my arm, and I haven't been able to grip anything for about a week and a half on this hand. So I went to MedSimple. I can show you online if you're sharing my desktop. And I went to MedSimple, and I had a problem in the left arm, and I went through and added all my history of present illness, where my pain is, how long it's been going on, what precipitated it, what went on, everything else. I put all that information in. I then print out that HPI, and I give it to the doctor, along with a list of 10 questions that I need to ask before I leave. What the doctor is it tells them not only that I know what the hell I'm doing, it basically shortens the amount of time they have to do in answering that information. They also can attach it to the claim and charge a higher E&M level because I've done the HPI, so they have 4 points, so they can bill the second level on the HPI. So they can, instead of doing a level 2, build a level 3 because of the work that I did. They don't have to do anything else. So I do that for me, and I've already done that for my visit tomorrow. And then for my mom, I do every time I go, I put the symptoms, how long is it going on, and I do the work beforehand so that I'm organized. And when I go to the doctor, I don't tell them a story about the fish tank and the oatmeal and the red SUV and I forgot to wear the sweater. I can focus on what the problem is because it guides me through and tells me this is what the mindset is. So it gets me in a mindset to communicate with my provider in a much more effective manner. That's how I use it. I don't know what you want to add to that, Francis, but that's what I do.
Yes, essentially, that's pretty much how I use also music that we work with right now at Smith Hangout. It's basically, in a way, we will have a little bit more efficient and accurate than their position, but a lot of them take care of it. People who basically take care of their parents, and sometimes of their kids too, who are at least the age of like 5 or you talk to the doctor also, their own opinion. But it's much easier for you to ask your mom and dad the question before you go to the doctor, and then they'll have mom and dad talk about this whether you know that not observer and in the visit, they discuss questions based on the history of that instead of trying to spend the time trying to get into the university.
And you may be too young to do this, but I guarantee you, before the next 10 years are out, you will go to the doctors, and after you leave, when you get in the parking lot, you'll say, shit, I forgot to ask him or her these 5 things. Because that's what happens. You get there and you forget. And you say, oh my God, I forgot to ask this question. We talked about this. We got sidetracked. MedSimple allows me not to forget. And that's the other reason why I use it, because it will happen to you. You will go to the doctors and you will forget one of the things you were supposed to do. If it hasn't already, you will forget one of the things that you haven't talked about. And it helps me not do that, if that makes sense. Oh, wow, yeah.
Yeah, yeah.
Yeah, fix those add new buttons on the on all the sections there. I can't use it.
Yeah, that's what we're working on.
Okay. Yeah, I added all my meds, but I can't add my surgical history, and I have a complex surgical history. So, yeah, but that's what I use it for. Because I have a complex surgical history. I had a stomach procedure where I actually had an ileojejunal anastomosis, so I missed the first 6 feet of my intestine. So why that's relevant is I can't metabolize vitamin B12. I can't synthesize vitamin B12 from anything, so I have to take it sublingually. And I also have a hard time. There's a couple other things, but keeping that history in there allows me to put really complex stuff that's relevant. I mean, if my doctors don't know that I can't metabolize B12 and I have to take it sublingually, a lot of stuff gets screwed up. So, I mean, but yeah, if you can fix that button, that would be helpful to me. I can add new surgical and medical history. I can add stuff from my dad, but I can't, I can't put my stuff. So. What else? Anybody else?
Good.
No, I know for a fact that Jessica's also interested in IDEO too.
Okay, I do. Yeah, I can't say enough about them. I mean, they really are an amazing company. They made a real difference in me and my ability to bring value to companies I've worked for.
That hypothetical scenario. Oh, that hypothetical scenario of crawling into databases and trying to make codes from different databases at least like talk to each other.
Yeah.
Is that even like possible? Like are there a lot of privacy barriers like to prevent that from ever happening?
I'm not talking about the patient level. What I'm talking about when I say a spider, I mean basically if I were to take 2 pieces of software and load them on the same network, I would want to have a spider, for lack of a better term, go and identify all the, first of all, getting the schema. It's not open source, getting the schema of the database, but being able to go through and identify the contents of each data field and mapping it automatically to the same data field in another application. So not from a patient perspective, but from the perspective of the database structure. So the issue becomes intellectual property and is it open source and is it ODBC compliant or not? Do you have the schema? Do you not? If you had all that stuff, it certainly is possible to do that. But nobody's done it yet. But no, it's not a privacy thing because we're not to the patient level. We're just trying to get application A to talk to application B.
Oh, by privacy, I mean, will companies even let us play with those 2 pieces of software? So if I wanted to build a prototype that crawled, yeah,
most of them won't. Yeah, it's intellectual property, so they won't.
Okay.
Yeah, I mean, that's unless it's if they claim to be something called. That's why one of the questions they typically ask if it's a large organization is your database ODBC compliant? Open Database Connectivity compliant. So if it is your schema available to us? Because even if they're ODBC compliant, who gives a crap? I need the schema. If I don't have the schema, I can't do anything. And if they don't give you the schema, you're kind of dead in the water. It'd be great if you could do it without it, but I just don't know how. I'm not smart enough to know. You guys are certainly way smart enough to figure that out before I would. I have no idea how you would do that.
Okay.
But if you're rewriting the database for Health 2.0, no problem. But yeah, I mean that's it's definitely an intellectual property thing, and I'm not willing to play in the sandbox, that kind of thing. It'd be great, but I mean that's really where the true innovation is going to come. Because right now the big buzzword on ONC for meaningful use is something called modular certification. What modular certification is basically I have a piece of software that does something. I need it to communicate with another piece of software that does something else. And I need it to communicate with a third piece of software that does something else. So that modular certification piece, that's the big buzzword, and that's where we're headed now. They complicate the problem. If there was a way to figure that out, that would be that'd be great. But I certainly don't.
Are there that many softwares even out there being used, though? Because, well, when I went to my doctors, they're all still using paper trails, They don't even have any software. So I feel like that's another aspect that can't even be integrated. Even if there was that spider, there's like half the doctors don't even have any software. So it's like, okay.
And why should they? I mean, nobody gave money to get it. Nobody gave them any money to do it. Yeah, it's exactly right. I mean, if you're paper, how are you going to do it? You know, so you have to get them using software. You know, and I mean, the hospitals are forcing it, but in the outpatient side, how do you do it? You know, that's why I say a whole generation of doctors has to die before it starts to really come around. I mean, the reality is now when you go to medical school, you're brought up with Adam. You know, you're brought up with software, you know, as a tool for you to do what you need. 10 years ago, that wasn't the case. 5 years ago, that wasn't the case, you know. But now you're brought up with technology. You're comfortable with technology. So all these docs who are in their 50s and 60s, I mean, I'll tell you, when I go into a practice and I'm meeting with a group of doctors, I look for there's two types we call them. The silverbacks. We call them silverbacks, right, for the doctors. And we call them blue hairs. The blue hairs are the billers. The blue hairs are the billing ladies. And they got blue hair, you know, and they just, you know, and they know billing and they use a pegboard and everything else. But the silverbacks are the doctors who, you know, they just pound their chest, you know, and I mean, they're going to do the way they want to do it. I told Francis, there was a doctor that I actually met who told me about EMR, he said, son, eagles don't fly in formation. About adopting EMR. So I laughed at him and I said, yeah, they're also on the endangered species list and you'll probably die alone. We're friends still to this day. But yeah, eagles don't. But that's the attitude. I mean, when you walk into a doctor's office, the attitude is, eagles don't fly in formation. You know, I'm not going to do this, you know. And then the other attitude, so there's that, so the silverbacks are the other one. The other ones that you meet are, I want to build a private rocket ship to the moon. Well, you know that NASA already built one, and we know it's a Saturn V rocket and everything else. No. I want to build my own private rocket ship to the moon. I know that it's already been done, but I wrote an EMR in my basement, and I want to reinvent this, and I want to build my own private because I know better. And that's, you know, the other angel of death that you'll run into as well. So these guys got to die off, and you got to get to the point where you have people who understand the value and what you're trying to do. And the reality is, as a young doctor now, you don't have a choice. You have to participate with the safety performance program. So even though you hate it, and Big Brother's looking over your shoulder, you don't have a choice. You know, these older doctors, there's another concept called concierge medicine that we didn't even talk about. And concierge medicine is basically doctors who have a built-in clientele who say, how do you want to pay for that? Cash, check, or credit card? I mean, you're like a plastic surgeon. So you built your client base. I mean, Dr. Nicolette Francie is in New York City, good friend of mine, and she's an OBGYN doctor, and she charges $9,000, $3,000 a trimester. You're knocked up, you go, $3,000 first trimester, $3,000 second trimester, $3,000 on delivery. You know, and then another $3,000 after the first visit. You know, so I mean that's, and she gets it. No insurance. How do you want to pay for that? You know, I mean but most doctors don't have the opportunity to do that. You know, most doctors have to take the HMO and everything else. So it's a tough environment. I wish I had the answers. You know, I'd be a billionaire. I'd still be on the Google Hangout. If I did have the answers and I were like the Steve Jobs of the medical world, I absolutely would still be here for Francis. But I'd have more than that little tiny, you know, refrigerator back here. I'd have much more than that. But.
Aww. Cute.
You know, we talked about it. The most important thing you can do is to make your patients collaborative with your technology, right? Don't alienate your patients, and don't do this. I can't tell you the number of doctors who have an electronic medical record and they say, okay, tell me about your headache. Okay, and how's that working out for you? And tell me what else is going on with that. Hang on. You know, I mean, that's the end of death, right? What you need to do, or what the idea you need to get across, is with your patients, you sit with them and you say, tell me about your headache. Okay, it's on both sides. Uh-huh. Yeah? It's worse. It gets better when you sleep. Okay. Medications help. Right, right, right. You have high blood pressure. Here, we took it this morning. Is that right? That blood pressure's right? Okay. Tell me about your son. Tell me about your husband. You know, you're married. Okay. You know, and I'm doing it with you. And I'm going, okay, tell me about that. No, you didn't mean that. Tell me what you, and you're collaborating with me. And you have the note. So it's not a hidden note. It's not like you're hiding it from me, because even in the paper world, what does the doctor do? They typically stand there and they write stuff down. You don't know what they're writing. But if you can invest and tell the medical students to engage the patient and not make it the mystery of medicine or the art of medicine, right? Make it a collaborative environment and engage with your patients, you know, and basically involve them in the process. If you involve them in the process, number one, they'll be much more amenable to you making mistakes. You know, I tell you, there's a really interesting thing that you should also remember when you're dealing with doctors, okay? And I didn't realize this for the first 10 years that I worked in the industry. But I talked to my dad, and I talked to a couple other doctors, and I never realized this. Every doctor who's out there, whether they've been practicing 5 years, 50 years, or 70 years, if you ask them, if you say, tell me the first patient that a mistake you made or might have made resulted in their death, and they'll remember. My dad remembers to this day a patient, and he might have caused their death, might have not, but how many other professions do you know where a mistake that you made might have resulted in killing somebody? Not many. You know, so when you're dealing with doctors and when you're talking to them, it's a pretty heavy thing, right? But think about it. I mean, these guys and these gals, you know, they will make a mistake. And that mistake may or may not lead to somebody losing their life. You'll carry that with you, that guilt, for the rest of your life. And it affects how you practice medicine. It affects what you do, you know. I mean, that's a really important thing to know. Knowing that and expressing that empathy to a medical student who hasn't made that mistake yet, and being sure that they understand that technology is meant to be collaborative, not exclusionary. I think those two things are going to be the sea change that is required to change the face of healthcare. I think there's a bunch of other things, but in my opinion, I think if you did those two things, express the empathy for the gravity of the mistakes that they are going to make, and the guilt that comes along with that, and the ability to make sure that they understand that their patients are not stupid and you can collaborate with them, and that you're seen as human, right? Because doctors used to not want to be seen as human, right? My grandmother, I told you my grandmother was a nurse. Do you know when she was a nursing student, they used to have to, when they were walking down the hallway, when doctors would come by, the nursing students were required to back up to the wall and put their heads down and wait for the doctors to go by. It's ridiculous. Now, I mean, you know, they say the only difference between a med student and a pile of dog shit is you don't go out of your way to step on a pile of dog shit. That's what they say now. But, you know, I mean, the reality is that physicians are still, quite frankly, held in this regard as not human, you know, as being super, as being able to play God. You know, I mean, they're saving your life. So, you know, I mean, that aura, that mystery, anything you do to further that divide really makes the fall when you do make a mistake that much harder, and makes patients much more brittle to mistakes and problems and everything else. But involving the patient, being collaborative, still being professional, I don't mean being not professional, but collaborating with the patient, in my opinion, is a way to engage them in a way so they understand what you're doing, they understand their healthcare, they understand that their choices, that they're being listened to, and that their choices affect their outcome. Right? It's not just you as the doctor, it's the patient, that the patient is collaborating in the process. I think that, in my opinion, is I don't know, Francis, do you disagree with that, or is there anything you can add to that? Yeah. Well, no, yeah. Notice I didn't say. I mean, my mom wouldn't go to the electric chair to do this, But you're going to have to help them, And I mean, you're adults now, right? You're going to notice a whole bunch of things over the next coming years when you go with your parents to the doctors. You're going to notice that they're human and they make mistakes and they don't tell things that they should, or So it's an interesting time, and I mean having the ability to affect that change. I mean, you're right. A whole bunch of patients are going to have to die off. I mean, if you think about it, the median age for cardiologists is 67 years old. Patients for cardiologists is 67 years old. For pulmonologists, it's 69 years old. It's 2 years older. And 69-year-old patient is not going to sit down and type down a Microsoft Health Vault, health record. Nonetheless, they're the ones who probably need it most because they're on 50 medications. Anybody else? So it's okay if you don't. I mean, look, I'm not the only. I mean, you guys. I'm not the only game in town. I mean, I get there are people who completely disagree with my point of view. I can only. This is only from my perspective, or from what I've seen. But there are plenty of people who disagree and think differently. So don't think that that I know anything.
I guess. I guess. Do you have any advice for young entrepreneurs trying to enter the healthcare scene? I mean, just what you've illustrated tonight is so complex. Like for someone like me, I'm not even necessarily coming from a healthcare perspective, even though I have family members who are MDs, and it's just so overwhelming in industry, and it's not really like clear how to even start to tackle this if innovation is something that we're passionate about.
I'm telling you, the first two things. If you take nothing else from this call, the purpose of everything we do. Again, speaking as a business, not as a physician, but as the business of healthcare. The purpose of any application you develop or any technology that you develop should be able to combine procedure codes and diagnosis codes to maximize reimbursement. And if you use that as a mantra, as the ethos from which you build everything that you're trying to do, okay, you will never go wrong. And the other piece of that, the other thing that you should take out of this is how is it going to get paid? Who is going to pay for it? And how is it going to be reimbursable? So if you can figure out a way to develop a product, service, again, talking about the physician side, a product or service that allows the physicians to combine procedure codes and diagnosis codes to maximize reimbursement while at the same time ensuring that it gets paid for somehow. Not just them get paid, but you need to get paid, right? So if you can develop something that does those two things as your ethos, it can be more complicated. It can do a whole bunch of stuff on top of that. But if you do those two things, anything that you develop, and you use that as your litmus test or as your rubric when you're going through, you will not go wrong. You will succeed. The other piece of that, the other thing that I would say is decide, don't try to do it all, right? You're never going to engage the insurance company, the doctor, and the patient. If you do, that's fantastic. But I can tell you, I don't think that there's a way to get all of them on the same page because the insurance company is in business to save money and to make money. They make money, right? The doctor is in business to make money and help people get better and improve the quality of patient care, right, and do what they got to do. And the patient's in business to stay alive and be happy and healthy. So getting them to agree and align when you realize all those things are you can't really resolve them together. And I guess the only other thing that I would say is know who your target is. It's a little bit different. So what do I mean by that? Epic. Do you know who Epic is? Epic Healthcare? Okay, Epic Healthcare, for those of you who don't, is the 800-pound gorilla. They are $10 million inpatient software product that basically does everything. It has meds and SnowMed, and basically allows you to, it does everything from an electronic medical perspective. If you go to a practice, if you go to a hospital that uses Epic, and you ask every doctor, do you like Epic? They will say, I hate it. It's the worst thing I've ever seen. I can't stand it. Epic doesn't, it's really complicated. Everything resides in 5 different places. You know why? Epic doesn't have anything to do with the doctor. It is not designed for the doctor. The doctor is not buying Epic. Do you know who's buying Epic? The CFO of the hospital, the chief financial officer of the hospital. If you go to the CFO and say, are you happy with Epic? They'll say, it's the best thing we ever did. I can't believe how fantastic it is and the amount of information that it gives me. Because Epic's customer is the CFO of the hospital, not the CMO, not the chief medical officer. So Epic's customer, as the CFO, if I view Epic through the lens of a CFO, I love what I see. If I view Epic through the lens of a doctor, I hate what I see. So that lesson is very important. With the product you're designing, who are you going after? If it's the patient, and I view this through the eyes of a doctor, will I hate it? Or can I like it? Or will I understand it? But if I'm viewing it through the patient, yeah, I see it, I get it, I understand it, But being aware of the other lenses and putting those other lenses on may help you innovate. I think that's where most companies make the mistake and fail today, is they invest and they go after the CFO, but they don't put other lenses on. This is what IDEO does that nobody else does, and this is why IDEO has been so successful, is they take opinions from multiple sources and different lenses, and they apply it to the same product. And they use those lenses and come up with a UI and a workflow and a design that no matter which set of glasses I put on, I like. And that, I think, is the big secret, is know your audience, know what lenses you're starting out with, but then be able to switch lenses and look at it from other lenses and realize you're never going to make all of them happy, but you should at least be able to see it through those eyes. And that only comes with hiring or being involved with people from different backgrounds. I forget who it is, who's doing the financial, who's with the financial company. Ivan, was that? Who's doing the financial analysis?
Oh, yes, Ivan.
Oh, yeah, that's me.
So that's that model where if you look at those companies who are looking to invest with healthcare companies, like CognoLink is another one that does stuff. They hire people, doctors. They hire analysts, people like me, nurses, lay people. And they look at things from all different perspectives, and they make decisions based on all the information they can get from disparate sources, right?
Right.
So that's really, from an entrepreneurial perspective, if you want to do it and you want to be successful, I think that. So you look at Kias as an example, Adam Bosworth's company.
Right.
Whose lens are we looking through? It's the patient, looking through the patient. But what has he done? He's also looked at the patient, and he's looked at it from the corporate wellness side. Where can I pay for? So I'm looking at it from the company side. So I've taken my patient glasses off, and I've put on my corporate glasses. And I can see the product, and I can see where the money comes from. So I've taken the same problem, and I've looked at it from a different perspective. So that's why your Adam Bosworths are successful. Versus another company that looks at it from one perspective. You look at like Medical Manager, right? The company I came from. Medical Manager did practice billing and management and scheduling better than anybody else. In fact, if you go to the Smithsonian Museum and you see Archie Bunker's chair, if you take 2 steps to the left and you look up Medical Manager version 5 is stapled to the wall. It's true. Medical Manager is the industry standard for what's out there for medical billing. Nobody uses Medical Manager anymore because it's a fantastic dinosaur, right? But it doesn't evolve because it looked at things only from the billing manager's perspective, not even from the doctor's perspective, from the billing manager's perspective. It's only when you take those glasses off and put on somebody else's that you can see and appreciate the problem from multiple locations. And that's why companies that do financial analysis, looking at different analysts from different aspects of healthcare, are going to be successful in investing because they get information from multiple sources. And an entrepreneur no different. You can invent the best mouth strap in the world, but if the person who's selling mouth straps hates your design or hates what you have to do, if it has a big Nazi flag on it, you're not going to sell any.
Right. Yeah.
I mean, so you have to look at it from multiple perspectives. So again, reiterate, procedure codes, diagnosis codes to maximize reimbursement, who's paying for it, who are you selling to, and how many lenses can I look through and still see positive benefit? If I had to boil this down to what you should take out of this, I think those are the things that I would take out of this if it were me.
All right.
But it's impossible to kind of make all lenses happy, you know, everyone looking through the lens happy. So
And that's what I said.
I feel like you need to specialize, even though you should know everyone's perspective, you need to focus on one lens or a few.
I completely agree with you. And let me clarify that. I don't think you should look at it and be happy with every lens you put on, but I think the more you look at it through multiple lenses and consider what the view looks like, the more successful you'll be, because it's the people who don't do that, you know, it's the ones who don't do that, who only look at it from one perspective and don't even consider the other perspectives, that you find people hate it. It's not that you won't be successful. There are plenty of people who do that, you know, but why is Apple successful? You know, well, because they have UI. They have people who do nothing but UI. They videotape people sitting at their computer, and they're using the software. They get a frame of their face. They match it to when the software, then they know what's going on, and they're looking at it from multiple perspectives, and they get a lot of different solutions. I agree. You need to focus on one thing, but if you can, you need to look at it from other perspectives. So all the Health 2.0 companies, as an example, who develop personal health records, I think I have one here. These guys right here, okay? You Be Well. I still have it in the plastic wrap, okay? I don't know if you can see it. These guys developed a personal health record, okay? And it's on a thumb drive. It's ugly, you know, whatever, who cares? But the thing is the output of this is a proprietary PDF file format. Can't do anything with it. I'm not even going to open this because I can't do anything with a PDF. What I need is that they looked at this and said, create this in a continuity of care document where the output is a CCD document and not a PDF. I would open this and use this every day because now it's consumable by every EMR application that's out there. And all it took was looking at this product from the perspective of a vendor. And they didn't. They looked at it from the perspective of a patient only and developed something that every patient can download Adobe because it's free. Great. But you know what? The purpose of this is to have your records and share them with doctors. Well, if you don't look at it from a doctor's perspective or a vendor's perspective so I can share information, it's a paperweight or a dust gatherer or whatever it is. But that's the point is that you're right. Focus on one, become the best you can be, but evaluate it from other points of view and make sure you consider, not that you're ever going to make them all happy, but if you can do something, or at least not even something, marketing. I'll tell you, a great marketing campaign can do a lot. I mean, even if you don't address those things, if you understand them, you can circumvent them with a marketing process and invent workflows and everything else, because really, that's really the key. I mean, there's plenty of stuff that's, I mean, the Apple phone, I mean, if any of you have an iPhone, you know there's plenty of things that are a nightmare. I mean, copy and paste, unusable. It's unusable on this thing. But you know what? They have a marketing program that says it's fantastic. You can use it. I can get around it, but it's the marketing program around it. So it's focus on the one, consider it from multiple, do everything you can do. If you can't you'll never make everybody happy, but you should at least be able to address it and talk to them about it and talk them off the ledge, if that makes sense.
Cool.
Anybody else? Have I worn everybody down? It's 2 a.m. my time.
Oh, geez. Where are you?
I'm on the Jersey Shore. I'm on Asbury Park.
Oh, I thought that was a joke.
No, the ocean's that way. It's like a mile that way. You know,
Okay. Well,
I don't live like, you know, with Snooki. You know, I met her once. I met her but no, I live in Asbury Park, where Bruce Springsteen's from, so it's much cooler.
okay. I'm originally from New York. My family's still there. My friends all go clubbing with Snooki and all those people.
Yeah, I met Snooki. I actually made her cry. We wouldn't let her into the club when I was working, and I was working at the front door, and we wouldn't let her in because she had flip flops on. The owner wouldn't allow flip flops. She said these flip flops cost $700, and I said, you paid $700 for those flip flops with that catastrophe of a hairstyle, and she actually started to cry.
Nice.
And screaming. It was fantastic. Yeah, so we're like this, like that.
I would have thought she'd gotten worse comments than that.
I'm sure she has. I mean, I was gonna ask her, with all those unpaid therapy bills, but I didn't. It was fine. It was all I could think of at the time.
Great. Okay, well, thank you for giving us this talk. I'll definitely give a follow-up email, and yeah.
Yeah, anytime. I mean, yeah, if there's anything I could do, you know what, I don't know if I could just send you a link or not. You might have gotten the link, but I'll email you the link for Prometheus. But yeah, anytime, just email me, and if you want to do another one of these, that's fine. I'll be happy to give you the time.
I'll tell Deb that I just spoke to you. I didn't know you.
Tell her I said hello. Please do, yeah.
Okay.
Tell her I said hello.
See you guys. Bye.
Thank you.
Bye.
Bye-bye.
Eugenia. Hi, Eugenia.
I admit I was a little over my head for a lot of the talk. It was a little over the head. I'll have to catch up. I have some catching up to do.
Yeah. I got a lot out of it, but it also means a lot more work, if that makes sense.